Bem, bom dia a todos. Hoje é dia 26 de setembro de 2020. Vamos começar mais uma transmissão aqui do For Valves TV. Hoje é uma apresentação especial com uma série de convidados internacionais, inclusive uma plateia presencial, como nunca fizemos antes. A apresentação de hoje vai ser em inglês, por conta dos nossos convidados internacionais. Então, a partir de agora, nós vamos trocar aqui para começar a nossa apresentação em inglês. So, again, good morning. Today is 9/26, 2020, and we have many guests today from the international board of our channel. We have Dr. Adolfo Guadagnoli from Córdoba. We have Dr. Mohamed Saraf from Alabama. We have Dr. Edwin Ho from Montefiore in New York, and we have Dr. João Cavalcante from Minneapolis Heart Center. And especially today, we have a special guest, our mentor, the doctor who inspired us to build this channel, Professor Francesco Maisano. It's really a real special day for us because we have started this presentation, this channel, with the inspiration of him. And I would like to, at first, to invite him to start his presentation. He will start talking about mitral valve interventions in 2020. Francesco, please, let's start our presentation and discuss about them. I would like to say we should maintain our style, and you can interrupt and interact during the presentation. Thank you, Francesco.
Okay, so first of all, thank you, Márcio, and let's go forward now. I will share my screen. It's not happening. So can you see my screen now? Huh? It doesn't work. The connection gets out. Yeah, problem with connection. I don't know. Lost at the Google. So we have to wait a second for our connections here. Okay. Okay. Interesting. Is actually manipulating my computer. I don't know how, but it's fine. Can you see my computer now?
Okay.
No.
But my mic,
It's
there's
yours.
no echo in my mic. I think Hello? Okay, I think that's okay. Yeah. Let's share the presentation of Francesco, yes. Okay, so.
Okay, I hope you can see my presentation.
In the YouTube, you have a delay by 20 seconds until the YouTube.
So let's start. So I will slowly enter into the discussion. I will make a little bit of an overview about mitral interventions. These are my conflict of interest. And I think today is a possibility to discuss about the new opportunities with mitral interventions. There is a lot of new evidence to support indications, decision making, and to expand the indications at the end to improve outcomes. But also in this environment, there is for sure need of education, need for training and exchange of knowledge, and this is one of the best opportunities to be together with esteemed colleagues and friends who share the same passion. Just let me give you a little bit of a perspective about my background. Yes. Louder. Okay. I hope they can see my presentation. It's a bit chaotic here. You know, my presentation is there, but I see there in the YouTube is me. One.
Look.
Fantastic. So, you know, today I talk to you about mitral interventions and endovascular procedures. It is at least 15 years I'm talking about this topic, and probably there will be some repetition. This is a very original slide at the European Association Cardiothoracic Surgery in 2005, where I was proposing the need for a new interventional surgeon. This was really, we were pretty much at the beginning at that time. And these are some slides. I don't want to go into the slides that I presented 15 years ago, but the same problems of 15 years ago remain today. We still debate how should we do, who should do this procedure, where should we do these procedures. There is still a lot to be understood. We are still in the learning phase, even in Europe, where probably the technology is more, the market is more advanced. Still, there are a lot of questions. And there is a lot of confusion. Many people in the world think I am not a surgeon. They think I'm an interventional cardiologist. And the problem is, I don't think there is much of a difference between an interventional cardiologist and a surgeon today. We are very similar, we think similar. We have probably different tools, we have had different schools, but we need to start thinking together. Why? Because it's obviously something which is happening in this evolution of interventions. We started, everything started with cardiac surgery. Open surgery was a revolution. Before the 50s, it was not possible to treat any heart lesion. And then with time, with technology, we come to the end today that open surgery is probably only needed in those patients who have contraindications for endovascular procedures. This will come sooner or later, just like happened for ASD closure, for balloon commissurotomy. I would say in Europe and US probably already for TAVI, we are already, aortic stenosis is becoming already like this, and mitral will follow soon. Now, my expertise is very specific in the mitral, and one of the reasons why I can speak to you about surgery and interventions is because I was together with Professor Alfieri, and I was part of this revolution. But I need to tell you also that these revolutions don't happen in one day or 1 year. This is a very long story. The very beginning of the idea of the Alfieri started in 1991, so it's 30 years ago, imagine. And the first time, actually, I proposed to think about the catheter was in 1997. We published 98, but actually 20 years to show that the idea makes sense. So this was the original publication. And how? It was not a surgeon to demonstrate. It was an interventional cardiologist. And that is the point. I mean, there is a continuous flow of information from the two professions. And obviously, to the demonstration that treating mitral valve with an interventional procedure may be helpful for patients, even better than surgery, because in heart failure, surgery has never been really successful. This was a real great achievement, and it was obviously followed by a big applause from the audience. If you remember what happened at TCT 2 years ago now. The COAPT trial has been a game changer to some extent for those who believe, because if you look at the numbers, there has been no such a trial in heart failure showing such a powerful impact on mortality in selected patients. This is a very selected population. And if you don't select well, you don't get the same outcomes. But still, it is how you get survival and benefit, and also quality of life and freedom from symptoms in these patients. Parallel to co-op trial, there is another trial which has been negative, or let's say neutral, but has been described as negative. And we still discuss it. Mitral FR has been a negative trial testing the same population, more or less, the same treatment, but at the end came out with no difference. And I will not talk about the difference between co-opt and Mitral FR because I am fed up about this discussion. I think we put too much effort into this discussion. There are many reasons why there are differences between the two trials. But what is for sure that these two trials bring a lot of confusion at the moment in the community. We don't know yet what are the best patients for these procedures. We don't know yet what are the contraindications for these procedures. And at the end of the day, the community, the referring cardiologists, the community cardiologists are still reluctant to send patients early enough to have a survival benefit. We learned that patients with very end stage structure are not the ideal candidates. The best patients are those who have been treated earlier in the co-opt phase rather than mitral FR phase. And there has been a big effort to identify the golden rule, kind of an algorithm to find what is the patient. The problem, this algorithm is based on the severity of MR, quantification of mitral regurgitation. And this is probably, in my opinion, the biggest mistake that you could do, because as we know, we are living with this mitral valve since years. And mitral valves was saying, Alain Carpentier, mitral valves are like women. The more you try to understand them, the less you understand. And the reason is that really this valve is very, very changing every day. Even the degree of regurgitation in a patient can be severe or moderate within hours. How you can make an algorithm based on quantification? And so probably, yes, patient selection plays a role. Probably, yes, heart failure therapy plays a role. Probably, yes, these numbers plays a role. But there is also a big role of procedural skills. One example, the last 3 years, we understood that we don't care about the amount of MR measured by gold standard echo. We don't care about the color. We don't treat colors. We treat pressures. We treat flows. And so we understood that LA pressure as you work. And we found out, and this is a study from one of our fellows in Zurich, from Shingo Kuwata, who demonstrated that those patients who have no reduction in LA pressure actually have no benefit from the therapy. So the target is not the color, the target is the hemodynamic. We need to go back to hemodynamics rather than to colors. I'm not saying we should not look at the echo, but don't take only one point.
Then you think that the imaging can be misleading to define how is our limits to improve the mitral? You think that you can reach the best level of atrial pressure than the image? Both.
Parameter to take decisions, because we don't have all the algorithms for everything. You should take all the information possible, and actually the latest generation of leaflet repair technologies, they all involve a pressure measurement. So you need to take everything in consideration. Before we were measuring online pressure, we were treating MR, looking at the color, but sometimes we were generating gradients. So you need to take both, and this table is very important. So we prepared to see the difference between what you achieve from echo, what you achieve from hemodynamics, and hemodynamics will not tell you if you have a durable repair. You need the echo to see if you have leaflet insertion, and you will not probably have the best left hemodynamics assessment with echo. You have better with pressure measurements.
Okay.
Really, you need to take both because every imaging modality gives you a feedback. It gives you an information. Now, this is also even more important as we become a little bit more sophisticated. I was very impressed 2 days ago. I was able to go back to the future. I use here in Brazil a very old system.
Yeah, that's it.
The Mitraclip NT, I think was the name. Now there is already the fourth generation available in United States, Japan, now comes in Europe finally. And this new generation has another problem. It's a solution, also a problem. There are now 4 different devices that you can implant in a patient. So you add some complexity in the decision making. You need to decide which one you need to use in these patients. And this is creating some we did some recommendations. You know, the experts, they always do recommendations. This is a table that has been given to the users to guide them in the decision. And this table is already wrong because the users, by using the device, already found out that there is, for instance, in this table, one questionable decision making, which is in patients with smaller areas, probably it's better to use longer clip arms because you can get a better outcome with single clips. So different from our, let's say, strategy, there's been already a feedback from the users. And however, it's important also to understand that there are opinion leaders, opinion makers, opinionated people. We give opinions, but often these opinions are wrong. So before you listen to the opinions, let's check the validity of these opinions with trials, with studies. And this is an EXPAND study. More than 1,000 patients have been evaluated with core lab and trying to answer to the question which device has to be used in which patient. So this will be the trial which will guide our decisions in the next 2 years. We're still looking at these patients. We are learning a lot, but there will be years before you get the full picture.
So we must customize the clip for the patient. Huh?
Exactly. And while technology is advancing, there are alternatives to MitraClip. PASCAL is another leaflet approximation device, which is similar, but also has some specifics. Is more flexible, probably in some situations may be more safe because it can be extracted easily in case it goes entangled in the cords. It has a spacer. It has independent grasping, so different features. And recently, John Webb presented good outcomes with this device, very good outcomes. I would say similar to what you get now in the EXPAND registries or leaflet repair work. And there will be very soon a trial comparing the two platforms. So we will also know probably which device is better for which patient. At the moment, looks like the PASCAL is a great solution for patients with central regurgitation, specifically with the functional MR. And probably MitraClip is more versatile for degenerative MR and patients with non-central regurgitation. But still, this is again an opinion. So we need to see whether this will be confirmed. There are many other tools. Angioplasty goes very slowly because it's more complicated to perform. It needs more imaging, more technology, but proof of concept is there, and these devices will come sooner to enrich our toolbox to treat patients to achieve at the end what is the surgical standard, leaflet and annual repair. And then you can really reproduce what is done in surgery. It's not only cardioband, there are other devices. There are also devices targeting the subvalvular apparatus, like the Ancora heart, which is kind of approximating the papillary muscles in functional MR. A lot of things, including replacement. And replacement, we do it since many years now, using off-label aortic devices in Baldwin-Bud, the Baldwin rings, and lately in Baldwin-Mac, and we will share this case later. Obviously, the technology that all we are waiting for is a specific device designed for the mitral. So a specific mitral valve replacement device which can be implanted in normal anatomies. We are waiting for this since now many years. And it looks like it takes longer than we thought before. And one of the reasons is leaflet repair is so good that now all the trials have to be confronted to edge repair. So this is, for instance, 1 year ago, the Apollo trial was updated to have a control arm with edge-to-edge. But still, I think there are some devices which are coming out, and Tendyne now is CE mark in Europe. And really, you can get outcomes in these patients. And Tendyne particularly can be a really good alternative for patients with complex anatomies. So we have data from also from devices from Edwards. The VOX system is a transeptal system, which is starting to be also available. I have specific experience with this Cardival, which is another transeptal system, which tells you it will come. There will be a transeptal system available in the market in the next 1 or 2 years, because it is feasible, it is doable, and technically speaking, is not that difficult to be performed. Also because imaging is improving, and you know, when you look at this cinematic imaging, it's amazing. It looks really to have a direct view on the structures, and imaging is so important for planning the procedures. This is a very important study showing planning of valve mech with Tendyne. Lately, Paul Soraja presented this data showing that in valve mech, Tendyne works very well, but also thanks to the pre-procedural planning. So that means start thinking that our procedure will be planned in future. We will use a lot of imaging. So is surgery at the end? So for those surgeons in the room, couple probably surviving surgeons, is the end of surgery? No, it's not. This is not the end of surgery. This is, I would say, a new generation of surgery, probably better surgery, because it's combining structural and functional improvements. So we see both structures and functional features of the structures that we are treating. And so we can go one step beyond. There is the big problem is that there is now a wider portfolio of options, and it becomes very difficult to understand what is the right decision for which patient, for which anatomy, and so on. And I have a privilege to be able to perform both. So for me, probably it's a bit easier on one side because I don't lose any patient. It's also a bit difficult because I have an internal conflict. I don't know in many patients which is the best solution. You see on the left side a minimal invasive mitral valve repair, on the right side a endovascular mitral valve repair. Well, I know that either way I need to achieve this kind of results. No MR, no stenosis. This is the achievement that you need at the end, and good coarctation and no residual lesions. And then you can understand, from my perspective, you can understand that for me, these two solutions are complementary. They're not in competition. Find the real indication for each of those. Only if you understand that these are not therapies, these are tools. And it's a problem. Mitral is not like aortic. We were discussing yesterday with you, Márcio. Yeah. Mitral needs expertise, specific expertise. So MitraClip for me is a tool, it's not a therapy. It depends on how you use it. A hammer is a hammer. And you can use it for kill a person or to nail, put a... So you need to know how to use these devices. So when we go back 1 second into the co-op trial, and everybody is on the podium talking about algorithms, timing, and so on, they forget the importance of the skills. You know, I see this kind of graphs, and I get crazy. I don't believe in anything of these guys. Maybe average, yes. In average, probably you can have an idea. But, you know, look is you have so much complicated numbers to try to understand if a patient will be a responder. You know, you have this kind of stuff coming from P-Baro. Nice try to make it an algorithm. Is it an algorithm? I mean, if I put, you know, this is the pre-procedural screening, then I put the clip upside down and all the screening doesn't work. So it's fundamental to focus on procedural skills, on knowledge. The operators around the table, and I'm not talking about the person who is implanting, I'm talking about the imager, I'm talking about the anesthesia, I'm talking about everybody, even the nurses, everybody has to be specialized. Because in surgery it's clear that volumes are associated with quality. This is very clear. Mitral repair happens more often in high volume centers. With MitraClip, we already have seen that volumes are associated with outcomes, although the learning curve to achieve an okay result, an acceptable result, is fast, 50 cases. But if you want to have a perfect result, then it's much more, it's longer. The learning curve is not ended after 200 cases in this analysis. And it's not only what happens in the room, but also what happens before and after. So we need to create this community. So we are in this case really depending on continuity of care. So for this reason, these meetings are important, like we did in the CAS. And I just want to celebrate CAS because we are all together to remember that this school was based on adult learning. We try to learn from each other, to learn from each other, using different tools, having mentors coming with expertise. Don't forget gray hair. I've seen many things. Listen to them. I'm getting older. Opinion leaders from all corners, surgeons, imagers, interventional cardiologists, everything. Manual skills, also important, but very important, group activity. We tried the hard time to teach Gustavo to cook some Swiss delicatessen. But I think, fondue. But I think it's much better picanha, sorry. I think. And we also learned during this COVID time, the hard way. We have been probably the first in the world to switch to an online learning, which will never replace what happens now that we are all together. I don't believe that we can survive as a community just with virtual friendship. Friendship is not virtual, it's real. So, as a conclusion and as a perspective for mitral interventions, first of all, the mitral valve is not one disease, it's many diseases, and we have at least to differentiate between degenerative and functional, or primary and secondary. And primary MR or degenerative MR in complex anatomies remains, and probably will remain for many years, a surgical indication, because it comes in younger patients, complicated, multiple lesions, and so on. But you need to have a good surgeon. Not every surgeon is so good. Second, there are still patients who can really benefit from repair with a leaflet repair, with an endovascular procedure, but again, you need to find a good operator to do that, because it's not that easy. Forget about replacement for degenerative MR. I mean, I hear a lot that the replacement will be the solution for everybody, but in surgery, for 50 years, we have been talking about this, and it's not a good solution. I should be only to patients with contraindications, so maybe with calcifications or other things. Functional MR is percutaneous, as well as tricuspid. Functional regurgitation is a percutaneous solution. We still have to really understand what are the right timing, the right indications for these patients, but I can see a big evolution of this field. So, revolution is the last message for you guys, because this is what happens actually. It's a big revolution. There are still a lot of new technologies coming, new interventions, which are asking for new operators. Imagine, we don't talk about it, but an echocardiographer who is in the operating room is a new operator. Was not like that before. The role of the echocardiographer in the operating room was to assess the procedure before and after. Now it's part of the procedure. So it's a new profession. There is new professions. There are new structures. Yesterday we were in a beautiful hybrid OR. Who was talking about hybrid ORs 15 years ago? Nobody. Then we need also new education. We need to understand that we need new professionals and new ways of learning. One important thing is that at the end, all this evolution is in sake of the patients. If you look at the STS database and the trend in hospital mortality for mitral interventions in the last 15 years, the mortality rate is decreasing in all procedures. Very important. By combining different approaches, we can save more lives. So don't forget that innovation at the end is good for the patient. And for those who didn't yet jump on the train, please, this is the last call because there is a lot of people doing this. Thank you.
Thank you. Thank you very much, Francesco. It's really difficult to interrupt you in front of this fantastic lecture again. And I would like to invite our international panelists, Dr. Sharaf and Dr. Adolfo. What do you think about this lecture of Francesco? Do you think that is born in another specialist, or you think that you can be an interventional or a surgeon and do this type of procedures? I'd like to hear your opinion about this. Mohamed, where are you?
Sure, yeah. Well, first of all, thank you very much, Professor Maisano. As always, very inspiring. So I think Professor Maisano summarized it quite well. There is no question that the transcatheter valve surgeries are not, I don't want to call them the future, they are the present now. I mean, in Europe, it's completely available, but I think for those of you who know me from CAS courses, I share a lot of the similar views, but I think when it comes to innovation, I love it. I personally, for those of you again who don't know me, I'm working on a TMVR startup company, which actually has a completely different design. The one thing that worries me in this journey, and we are going to make mistakes, there's no question about that, but and we're going to learn from these mistakes. Experience comes from mistakes. But I think part of it is that too much enthusiasm probably can steer us away from better goals. Again, I'd like to focus a lot on flow dynamics and how the nature works. I personally believe that we have to, as Victor Schauberger used to always say, comprehend and copy nature. I think we have to, instead of focusing too much on technology and trying to get something approved, we have to be a little bit cognizant, especially as scientists. I think we have to police ourselves in the way that we are pushing the evolution of these technologies forward. I think for those of you who might remember that we had a discussion about Loris TAVR as an example. I'd like to take TAVR as an example because it's a very mature technology and everybody thinks that, okay, do we even need TAVR? I remember that in one of the debates that we had, I was against Loris TAVR for all patients. And if you pay attention to the 2-year results of S3, clearly the TAVR arm still is superior, but all the death and stroke and disabling stroke that was strongly in favor of TAVR seems to have been washed away in 2 years, and who knows what's going to happen in 5 years and certainly 10 years. So I think it's truly an exciting time to be either a cardiovascular surgeon or an interventional cardiologist or an interventional echocardiographer or an advanced imager. It doesn't matter. It's just a great time to be in cardiovascular medicine. But we have to keep our biases away in this journey. We have to follow the natural laws of nature instead of trying to, I always say this, that we have come out of nature. We have to follow the rules of nature, not the other way around. We cannot put a circular device into an annulus and hope that it's going to work. And this is something that Professor Maisano and I are basically focusing. We really want to team up together to understand physiology at a much deeper level and try to apply the laws of nature. And hopefully we can design and innovate together in a way that we can also respect the laws of nature. Sorry for the long response.
Good point from Mohammed. Obviously, you should remember that definition of inventor by Nikola Tesla was the one who is able to overcome nature. So probably you're not like Tesla. Yeah. You're more Edison.
I will never be.
Thank you, Mohammed. I'd like to hear Dr. Adolfo. Hi, Adolfo.
Unmute yourself.
Yeah.
You're muted. Can you speak a bit louder?
No, I can't hear. I hear. No, I can't hear. His mic's not mute, but I can hear him. And for a while, let's hear Edwin that attends the CAS, has attended the CAS. And hi, Edwin, how are you? I'd like to hear about the speech of Professor Maisano.
Yeah, I think that was a fantastic and I agree inspirational overview in terms of what's going on in the field for mitral intervention at this time. I think as an interventional imager, I completely agree with this idea of, restructuring what the team involved with these sorts of procedures and interventions and what that actually means. And I think from my point of view, what that also tells us is that I think we always need to be ready to continue to adapt, because this is certainly a field and an area that's going to continue to change and probably quite rapidly on us. And I think we need to be ready to actually go along with that so that we can actually accommodate to anything that's coming in the future, basically in order to offer our patients the best outcomes and best options.
Thank you, Edwin. Let's move on. I would like to invite Dr. Joao Cavalcante to share your screen and to start your presentation, please. João, thank you for your participation here in our channel. And now we are talking about planning in CT, this kind of procedure. João, please.
Thank you, Marcelo. I hope that you can hear me okay. It's a true honor to present here on behalf of our institution, Minneapolis Heart Institute, to this great group. Sorry that we can't be in Brazil at this point in time, but hopefully soon establish some normality. And some of my disclosures relevant to this presentation is the fact that we participate in many trials through Minneapolis Heart Institute, and particularly the Summit trial that is also investigating the use of the Tendyne in MAC. In mitral annular calcification, there is certainly a great deal of understanding of why does it happen. There's a lot of similarities to coronary artery disease in the sense that similar risk factors, such as increased age, chronic kidney disease, all the risk factors for coronary artery disease are very similar to the development of mitral annular calcification. It is a process of repetitive, similar to coronary artery disease, repetitive injury and repair, and with that comes calcification. And whenever there is repair, there are inflammatory cells that bring out inflammatory cells, and they start to have a party. And then was what once was started in the posterior annulus, which has the largest area of contact. Think about the anterior mitral annulus or mitral valve leaflet as the toilet seat that opens and closes and favors the left blood flow into the left ventricle. The posterior is the one that has to provide the anchoring most of the time, and therefore it starts there. Over time, this process that starts in the posterior annulus is going to then affect the trigones, the anterior mitral valve leaflet, and then therefore it can then have a prevalence, depending on the cohort and the methodology that is used, up to 15% of the population. Obviously, in certain groups of patients, this can be even higher. This is a beautiful work actually by the group from Edinburgh in Scotland, showing that MAC is an active in progressive disease using PET fluoride in patients that had sequential CT scans for the aortic valve disease. The presence of MAC is common in these patients with aortic stenosis, and they could see that MAC was present, had follow-up CTs, and they saw that this activity identified by the macrophages in the MAC was associated. The greater the activity, the greater the progression. So we think that this is just a passive, but actually continues to grow, just like in the aortic valve for the aortic stenosis. Now, my assignment here was to talk about the CT in the context of transcatheter mitral valve replacement. We'll have a nice case that Gustavo and Francesco have been involved to, and we're going to be discussing a little bit more in details. But, CT has obviously provided this very granular detail analysis that is very important for the patient selection, the safety of the procedure, and the procedural planning. In the presence of MAC, obviously, this mitral annulus becomes quite distorted, and every MAC is different from patient to patient. Therefore, the segmentation has to find some rules, particularly for the trigones, particularly for the understanding of what would be the Neo-LVOT, which is the residual space or area that this patient would have once the valve is placed in the presence of the anterior mitral valve leaflet. Some grading schemes have been proposed. This one here by Macram, lead from Mayo Clinic, showing that in the presence of MAC greater than 270 of the arch of that mitral annulus would be present. This would be considered severe and less so if moderate. And when we think about sizing for CT with MAC, we wanted to think about three crucial things. We're going to size the annulus, which is actually going to be above the MAC for fixating that valve. We wanted to avoid LVOT obstruction, and we wanted to establish, obviously, proper valve function. And we have to be able to achieve all the three components. MAC is actually subannular. You see in red the tracing of the annulus, but you can see that this MAC is quite invasive and sits right underneath the annulus and into the myocardium as well. And so the fixation of that valve is going to occur actually at the subvalvular annulus, where we trace is actually the area, perimeter in that case, also the red part, which is the annula. But when we think about that, we need to have three landing zones, if you will. First one is here at the mitral annulus, which is where we're going to try to keep that fabric to avoid the leak and to avoid great sealing, to have great sealing. We wanted to have the other landing zone, which is the anchoring part, which is that the valve at the MAC part, the MAC for the anchoring here. And also we wanted to make sure that this patient would have enough LVOT so that we can have enough passage of blood flow and not cause a harm. So this is an example from Didi Wang from Henry Ford Hospital, who was one of the pioneers along with Myra trying to tackle this very challenging cohort of patients. And you can see here on this black arrow the mitral annular calcification being subvalvular, subannular, and extending into that and being this double balloon inflation to trying to improve some outflow tract in a patient that had problems with left ventricular outflow tract obstruction. This business of trying to put sapien into MAC was attempted by Myra at the time at Henry Ford initially, and then at North Shore, showing that the first half of patients, so what this Francesco just spoke, that we continue to learn. We need to be nimble in terms of trying to reinvent ourselves as well as to adapt and change and relearn. It can be seen in the results of this mitral trial. The first half of patients had a 30-day mortality of 31%. That's 1 in 3 patients. And a lot because of issues related to valve embolization, related to Neo-LVOT obstruction, and not proper sizing. In the second half, it improved quite significantly, but still 1 in 5 patients, 20% 30-day mortality. Obviously, we're trying to use an aortic prosthesis into the mitral valve annulus, which is quite complex. And this is an example that we had done back at Minneapolis Heart Institute, and you can see that there is a narrow passage here that was responsive to fluids, and this patient did okay. There was a good circularization. And one of the predictors for success, particularly for the valve MAC, is obviously the measurement of the Neo-LVOT. This is a series from Cedars-Sinai, Raj Makar group, showing that this calculation of the Neo-LVOT, especially if above 1.7, some people say just put 200, is a safer zone in which one could be considering to establish this in more safe grounds. And you can see that the LVOT obstruction tends to be much more common when the anterior mitral valve leaflet is present. This is in the case of valve MAC and the valving ring. In the valving valve, we already have that docking station there, repairing the landing zone by the prosthesis, the surgical prosthesis. Now, more recently, a couple months ago, there was this paper, another extension of the mitral trial, published again by Myra, trying to use some of the learning concepts that were developed into classifying, giving a little bit more granular detail of the MAC score. This is based into 4 components: the thickness of the calcium, the distribution, the trigonal involvement, as well as the leaflet involvement. And then each one of these patients would have the calculation, and you can make this, and you can see that in patients that tend to have this MAC score 7 or greater, would have enough calcium that you probably would be safe. But those are some examples. You can see here the 270 degrees of calcification, involvement of both trigones, posterior and anterior annulus. You can see the thickness of the mitral annular calcification is quite good. Also, proper segmentation. We should not come all the way inside here, but try to use the trigones and measure the anteroposterior, intercommissure, and trigonal to trigonal. But when we look into this paper more in details, there were 117. There were a lot of those that were excluded because they did not have good CTs for evaluation for the presentation. You can see that the technical success was about, third of these patients did not have good success. A lot to do because of valve embolization migration. So when they looked back and did the data, there was almost half and half of these patients. Half of them were properly sized, which you had a range of area between -5 to 20% of area oversized. And another half of the patients that were totally undersized. And the price that was paid for those that were undersized was actually they had obviously all the embolizations happen in these patients. And in 3 of them had migration of the prosthesis, obviously more upward to the left atrium. There was no differences in the MAC score between those that were under or oversized. But even in those that were normal or oversized, there was still migration. And when they did the multivariable analysis, they saw that the presence of a MAC score less than 6 was associated with a borderline p-value here to be a risk here for embolization. So this is just one of other variables. I still believe that undersizing is critical, important for this patient. That's not to say that this odds ratio is not significant. It's just a small number of patients to give this wide confidence interval. But I think both components are important. How much calcium one has, but also proper oversizing techniques and obviously a better device technology. We talked about anchoring, we're talking about LVOT obstruction. So what can we do for these patients that now we have good sizing, but the problem is the LVOT obstruction? Simulation is an important. Didi Wang from Henry Ford, working with Myra, had shown initial cases that for patients that would be with the Neo-LVOT calculator less than 190, there would be a high risk. Again, 190, 170 would be a high risk for obstruction of the Neo-LVOT. Some other works have shown that actually the percent of LVOT loss, so could say that even sometimes between 50 to 60% of that loss could be associated with increased gradients, but definitely obstruction cause hemodynamic instability would be in this range. And one technique that could be utilized is obviously trying to then create more Neo-LVOT space by doing preemptive alcohol septablation. The alcohol septablation as a bailout, as a rescue therapy for these patients, it's typically disencouraged because of the uncertainty that this adequacy of the alcohol septablation could be at the immediate short-term time. And not to say also that there is a rebound effect, that because of the toxicity from the alcohol, edema, swelling can occur, and then they can have a paradoxical response. It looks great in the first day, then day 2, day 3, they can re-obstruct again because of this wave of the inflammatory cells. Preemptive alcohol septablation was studied in this cohort of 30 patients by, the Henry Ford group. The median septal thickness was 1.3.5, so not too thick. This is the range. And ventricles were typically small with preserved ejection fraction. And they re-imaged these patients 40 days on average after their alcohol septablation. And what they saw is that on average, about 111 patients, on average, the area increased by about 111 square millimeters. And you can see that a lot of these patients benefited from the alcohol septablation to the point that even some patients did not even underwent TMVR anymore because there was improvement of the left ventricular outflow tract, which is a bit unclear why. But also is not, even though we are trying to do this before the procedure, there were 2 deaths, one related to loss of capture of the pacemaker and pacemaker rate of about 17%. So we're trying to continue to iterate and do better, and this is an area of active research. The other potential to do here is to do a LAMPOON. What the LAMPOON is a percutaneous laceration of the anterior mitral valve leaflet. There is a LAMPOON that comes with an electrocautery at the base of the anterior mitral valve leaflet, which will be displaced anteriorly and covering the open cells of the sapien 3. And if one can cut this anterior leaflet and open this as a window, then the flow could come through these open cells. And so what we have to see, and this is an example, you put a sapien 3 into the outflow tract and you measure the Neo-LVOT, and it is actually very small. And if you do the LAMPOON and you open it up, then what you need to measure then is this space between the skirt, the ceiling skirt, to the Neo-LVOT. So it's called the skirt Neo-LVOT area, and you can see that this improved significantly to a much bigger area. And what they have seen is that in patients that typically have this skirt Neo-LVOT area greater than about 150 square centimeters, those patients tended to do well. This is work by Jafar Khan from the NIH, Washington MedStar Hospital, a very important work and another modification of the Neo-LVOT. And this is work from us here at Minneapolis Heart Institute using a different prosthesis, a Tendyne we'll talk about briefly, doing preemptive alcohol septablation and significant augmentation of that area and safety of the procedure. So in terms of MEC, also device changes have been developed, and one of them is the use of the Tendyne. This was the first compassionate use of this woman. It had this very aggressive circumferential calcification invading the myocardium as well. And you can see that the annulus that was calculated was way too large for any sapien prosthesis that we could put there, and would not have enough sealing, not have enough anchoring. And so the Tendyne was utilized, and the Tendyne has 2 parts. There is the valve, and there is this apical pad, and there is a tether that connects the 2 of them and provides stabilization and fixation of that prosthesis. We did the simulation along with Abbott, the company too, and Neo-LVOT was about 3.1, so safe grounds there. Simulation with mimics, with overlay of the STL file, and also important to understand what it will be the mobilization of the spicules of calcium involved in the trigones, which tend to get displaced. We can see that with balloon dilation. This is the transapical axis, the flossing and the rail created by Paul. across the mitral annular calcification, and then the balloon inflation to prepare that landing zone and to see the displacement of the calcium, and then the deployment of the prosthesis with no LVOT obstruction. And this is the follow-up CT demonstrated adequate seating of the prosthesis and the first compassionate use. Now, fast forward to this publication from last year for the first 8 patients. Yes?
It's Gustavo. Just a question. Do you...
Go ahead. I'm sorry, Gustavo?
You use Sentinel or...
Device embolic protection for these patients, and the answer is no. We don't use Sentinel device protection. We see that this calcium is actually it doesn't give up. Its calcium is stuck. We have not traditionally used, for these procedures particularly. Is that what you were asking? I believe there's some delay here, so I will continue. And so the first 8 patients were presented at EOPCR and then published in
João. Can you hear me? We can hear you.
I can hear you, Gusti, but I can hear Joao.
João, we cannot hear you.
I can't hear him either.
Sending him a message, Gustavo, is better because probably he is not able to listen us.
For sure, because he's still talking.
João. João, can you hear me? Okay. We cannot hear you. I don't know what's happened in the final.
Let him know.
Joao, the last 3 minutes we couldn't hear you.
Yeah, we cannot hear João for a while. Let's hear about something about Adolfo, about the last presentation. What do you think, Adolfo, about planning with CT in this scenario of MEC while the technique solved the problem with João?
Well, thank you, Márcio. I think, as you know, it is the key. And we know some issues that we have to solve or what we have to fix before coming into the cath lab, and the CT is going to make you know exactly your patient. So there are some tips that I would like to remark or to highlight that Joao says. I think that, I don't know what Francesco thinks about this, not algorithm, or this way to predict how you can fix the valve that was made by Mayra Guerrero. I think that if you follow these all types of calcium and the localization, I think that you can easily predict if your valve is going to fix properly. But then you have to predict if you are going or not to have some issues with the LVOT, which is normally a nightmare, because if you you were not able to predict that it's going to happen, the LVOT obstruction, your patient for sure is going to well, I don't know, die, but he's not going to be as good as you think before. Francesco, what do you think about this score calcium or score MAC prediction?
Good, thanks, Adolfo.
So is it good enough?
Can you hear me now?
Welcome back. Yes.
Adolfo.
I'm so sorry here. I don't know.
Should I answer, Adolfo?
Yeah.
Adolfo, my answer is very simple. All these algorithms are very useful in the average, are very unuseful in the single patients. I don't believe in any of these algorithms taken in isolation. I don't believe in the height of the coronaries for the risk of coronary obstruction. I don't believe in the sizing chart. I don't believe in any of these numbers in isolation. You always have to remain critical in front of these algorithms. You need to become expert of the imaging that it works for you. So I, with all respect for Joao, I love to hear his voice, and we will discuss the importance of his voice yesterday. But I will never go blindly into a procedure with the report of somebody who will not be with me in the operating room. So you need to get this information. These are obviously driving our decisions, but the devil stays always in the details. So I think these are structural interventions, and you have to have a structural mind, not a mathematical one.
Okay. Any question of the audience, the real audience here? Yeah. Okay, Vinicius.
Professor Maisano, I want to ask you a simple question. Do you think that the transcatheter mitral valve replacement device will replace the edge-to-edge device in the DMR in the near future?
So my answer is I believe not. Although we will see many institutions shifting from repair to replacement because of the reproducibility. And, you know, this has been already seen in surgery 40 years ago, 50 years ago, when at the beginning there was no prosthesis available. Everybody was trying to repair. Then came the prosthesis and everybody was implanting prosthesis. And then we understood that repairing in some patients is a better option. So it will not disappear, although edge-to-edge obviously is, we need to see, I mean, whether there will be anything better for DMR. Maybe we will have other solutions, but repair at the end of the day, you know, there is nothing as durable as a natural leaflet. Whatever we do with replacement is not the same, and there are many reasons. The most important reasons I think are, you know, we need to ask Mohammed. But if we ask Mohammed, then we don't talk about other things anymore.
Thank you. João, we can try again.
Yes.
Let me
Can
see. We cannot hear again.
Apologize for whatever happened here.
Sorry.
I lost connection.
I'd like to. Yeah. Okay, great. For a while, yes. Let's end your presentation to change the Edwin, please.
Yes. All right. So I will apologize again. So just to conclude, and I hope that you were seeing the presentation about the Tendyne MEC, which has now expanded now into the Summit trial. 15 patients have been treated, and that perhaps could be a good device in the proper selection, which is mostly echo NCT based, obviously to come prepare, has been very successful. And also it will be important for the future that we consider that the clip or the transcatheter edge-to-edge therapy is not a potential for other repair techniques or for other strategies. This is a case, first, that using the same electrocautery and the V, the flying V. Paul did the cutting of the anterior mitral valve leaflet in this patient that had 2 MitraClips that now present with severe MR and had the tendine already prepared. He cuts the anterior leaflet and deploys the tendine. And you can see that there was excellent results in this patient with a tendine in a patient that obviously is significant high risk. And that this is the CT following up 30 days that we have at our institution, showing the good fixation of that tendine prosthesis and the fixation of the apical pad, which is something actually that we are researching now on how can we do better, because despite the apical tethering pulling back the left ventricle, not all patients have reverse remodeling. And what we have found is that the further away from the true LV apex this apical pad is located, the worse will be the left ventricle and the left atrial remodeling. So in conclusion, MAC will continue to evolve in our understanding. The therapies that provide annuloplasty for the mitral valve obviously do not want to see MAC, but in certain MAC TMVR trials, actually this is necessary for the proper anchoring fixation. It depends on the device that you will be using. Cardiovascular CT, I believe, will continue to provide this very granular anatomical and functional detail pre and post TMVR. And the technologies of TMVR will continue to undergo this organic natural selection for the identification of potential viable strategies. And to try to think about permissible adjunctive therapies would be important in the future if we wanted to move along. And with that, we'd like to conclude. And thank you again for this opportunity.
Thank you, João, for this great presentation. I would like to invite you to stay here with us and to comment the CT of the case. And Edwin, I would like you share your screen to start your presentation. And for a while, my friend Mohamed, do you have anything to say about this presentation?
Oh, no, that was great. Thank you very much, Dr. Cavalcante. I just wanted to ask a question about the 11 patients that you've done. How many of them the indication was mitral regurg along with MAC? And how many of them you treated because the gradient was high, but there was no mitral regurgitation?
Yeah, so good question, Mohammed. Majority of these patients were treated because of mitral stenosis. So about 70% of them, 30% of them had mixed mitral regurgitation, mitral stenosis. And that's one of the reasons that we decided to have that arm of the Summit trial now for the tendine in MEC, because there were a lot of patients that, as you know, have mixed valvular disease, and they could still potentially benefit, provided that we, have the boundaries of all the selection process that we described. So
the reason I'm asking this question is that I'm still trying to understand whether even the term calcific mitral stenosis really exists, even if the disease exists. And let me explain why. What's the average mitral annular area or inside the calcium area that you measure on average?
What is the calcium area that we measure on average? Right. Yeah, it's in the order of thousands, so depending on
choose the size of the valve.
Yeah, so the depends from patient to patient. It can go from 800 to sometimes, the area can be from 800 to sometimes 1,000 square millimeters of that mitral annular area. Yes, encompassed by sometimes it can be from 400 to 800. It changes from patient to patient. Now, the calcium volume, which is the amount of calcium, is also extremely variable, and we can do that segmentation.
Right. So that's my question. Let's say 800, 900. So that's essentially like if a surgeon places a 29 or 31 millimeter bioprosthetic valve inside a patient. And that's why I don't understand whether we are treating a number or not. What's more, what I'd like to know is, does the gradient change after we put the valve in? Because I cannot imagine that we put a bioprosthesis inside a calcium that, let's say, that has an area of 950. I assume that we probably at least take away another 100 millimeter of square from inside the calcium. So what I'm trying to say is that I can't understand why we want to do valve and MAC. And by the way, I do it. It's not that I'm against it, but I'm trying to keep my mind and eyes open for because it's very easy to be skewed in and be hyper focused on what we do, and we keep doing it, but maybe it's not the best thing for the patient.
No, yeah, I think what you're trying.
Yeah.
Go ahead.
No, please go ahead. I think you got the question.
I think what you're trying to highlight is that, what is the importance of the device selection and transmitral gradients pre and post this procedure, and what would be the downstream impact. I mean, we measure left atrial pressure, as you know, and that left atrial pressure decreases, particularly in the presence of mitral regurgitation as well as in mitral stenosis. But, we are using, particularly for the sapien valve, a aortic valve into the mitral position. Obviously, we don't know the long-term durability, and none of these patients have lived enough that we can learn from. But it begs the question whether or not our strategy, and I would even argue too that the valving valve that we use, even though there you already have a docking station, a preparing landing zone, whether this is a durable solution. Obviously, we're dealing with patients that are living longer with tons of heart comorbidity. So what would be the alternative that we have? We don't have, but could we improve into the device hemodynamics and mechanics so that we can provide even a better solution for them? I think that's to be answered.
Okay, thank you, João. Thank you, Mohamed.
João,
this fantastic speech. I would like
Yes.
to. Sorry, Gustavo.
a question. João,
just one moment. Edwin, can you share your screen while we discuss again? Could you start to share your screen, please? Gustavo, go ahead.
João, as you have João and also Mohamed and Edwin, because you are working in the US, as you have Tendyne available and also S3 available, how do you feel about those devices? There are specific indications, or you think one is perform a little bit better than other? How you choose it? Once we get here, so we're gonna have your experience.
I'm sorry, just summarize it quickly. We don't have access to a Tendyne yet, so I'll let Dr. Cavalcante or Edwin answer.
So, are you talking about, Gustavo, in the context of mitral calcification?
Mac, yeah.
Okay, so yeah, I think Tendyne in Mac, it's possibly to this date the one that we continue to have the largest comfort with, provided that we can have the adequate selection of these patients. Again, when we look at the data that Paul presented at the EuroPCR this year, now there's still a screen pass rate of about 30%. So 2/3 get excluded because we don't have, even with the low profile Tendyne, enough space for those ventricles. Remember that mitral stenosis causes ventricular underfilling. And this is a problem because these ventricles sometimes can be hyperdynamic and will not tolerate. So yes, for us, we believe that Tendyne represents a better strategy than the Sapien 3. But we still, for example, M3, we cannot put that into Mac. I mean, a lot of these devices for obviously transcatheter annuloplasty do not accept patients with Mac. Still an unmet need.
Okay, can you hear us, Edwin?
Yep, I definitely can.
Okay, could you share your screen and start your presentation about echo planning the mitral interventions, please?
Sure, I have it shared, I believe.
Yep, please.
Can you see this okay?
No, not yet.
No. Okay, let's try again.
We can see you, but not your presentation, Edwin.
Yeah, that's it. And can see Dinaldo. I didn't say hello, Dinaldo. How are you? Dinaldo is a fantastic doctor, interventional cardiologist from Recife, the most beautiful city in Brazil. And hi, Dinaldo.
I agree, Márcio. While Edwin is preparing, I have a thing to reflection. Each MAC patient is different from another patient. MAC is a very, very different disease. It's very a lot from patient to another patient. So maybe only one device should not fit all patients with MAC. It's my opinion.
Okay, great. Thank you. Edwin.
Now Edwin is perfect.
Okay, great. Good to hear. Okay, so I'm going to spend the next little bit of time just discussing the role of 3D echocardiography. My focus here is more so for mitral regurgitation assessment. We just had a very nice overview in terms of assessment for procedures in MAC. 3D echocardiography has some role in that type of assessment as well. But one of the disadvantages with echocardiography is that, especially in 3D modalities, is that we do lose some spatial resolution. And then in the setting of calcium, there can be a lot of blooming artifact and side lobe artifacts. So certainly, I think CT is very much superior in planning procedures like that. With that said, I mean, echocardiography is still key in guidance in those types of procedures. So it's still important to be able to use these same principles in those situations. So just focusing now more towards mitral regurgitation, let's start talking about how 3D echocardiography has some advantages over 2D. So I have no relevant disclosures. And then quickly our objectives. So I'm going to focus mostly on transesophageal 3D echocardiography. Transthoracic can be used in very similar ways, but of course during a procedure we're using TEE. And then in terms of the mitral valve, because of the proximity of the probe, and certainly TEE gives us significant advantages in terms of spatial resolution. So we'll first talk about how we assess the anatomy, which is probably the most important component when it comes to echo, and then also assessing mitral regurgitation, although we've heard that there can be some caveats and downfalls of that. And then also we'll mention a little bit about procedural guidance and how some of those tips have actually been brought back towards the pre-screening assessment. So first looking at the anatomical assessment. So if we think about the mitral valve in a surgical view, so usually we would orient the valve in this setting, and then we think about all the components of the valve and all the aspects from lateral to the medial aspect. If the patient has significant mitral valve disease, we obviously want to know exactly where the problem is and what that problem may be. So if we think about how we actually assess that with echo, the most common way to do this is to use 2D methods to do multi-plane mapping. And what that means is in the mid-esophageal position, we would actually change the angle of the imaging plane to try to sweep around the valve in 360. And what that does is it allows us to actually see every leaflet segment, again, to understand the disease process there. And then similarly with color Doppler, we can see where, for example, regurgitation is coming from. There is a big disadvantage of using this technique, which is that we rely on typical anatomic landmarks such as the aortic valve to tell us what part of the valve we're in, but the relative position of the aortic valve to the mitral valve can be variable depending on the individual. In this particular case, the aortic valve actually sits quite nicely at this 12 o'clock position, but in a lot of patients, it's actually deviated towards the left. So it could be closer to 10 o'clock or 11 o'clock. So if we just purely use the aortic valve as our landmark, we may be wrong. The other problem is that these red lines show you how we would use the multi-angle to actually assess the valve leaflets. And as you can see, we're often cutting the valve in an oblique fashion. So we're not really seeing physiologic pairs of leaflets as they would normally co-opt, and then potentially for us, how we would actually want to intervene and assess that intervention. So what other options do we have? So again, here's an example of what that would look like in terms of doing a multi-angle assessment of the valve. And as you can see, probably the best example would be at our 120 degree or the 60 degree that really doesn't quite look like typical leaflet pairs. So again, we may be wrong in terms of what we're actually looking at. So now let's think about what our alternatives may be. Again, with 2D echocardiography, we can actually do a sweeping technique where we can find a good imaging plane that gives us leaflet pairs as they co-opt, and then sweep the probe by rotating clockwise or counterclockwise to again see the valve from end to end to understand what's going on. The problem with this is it still relies on those same anatomic landmarks. So we could be wrong in terms of thinking where A2P2 truly is, and the orientation of this imaging plane may still be incorrect. So how can we use 3D echocardiography to improve this further? Biplane imaging is based on 3D echocardiography, and what it does is that it allows us to image two different angles at the same time. So you do need a 3D ecosystem to be able to do this. And it helps us in assessing the mitral valve because we can find a very good optimized intercommissural view, which is demonstrated with the red line here. And that angle will vary depending on the patient. And then we use the biplane, which are the yellow lines, to actually be able to sweep end to end on the valve. And in addition, we can change that secondary angle to, again, really optimize to be perpendicular to the coaptation line so that at the 3s and the 1s, we're again seeing the valve exactly as it should co-opt. And for example, if we're doing an edge-to-edge repair, exactly how we would actually want to intervene. In terms of what that actually looks like, you can see here is a good example of biplane mapping. So we're seeing the 1s, the 2s, and 3s by sweeping the biplane cursor across the valve. And you can see there are differences here in terms of this patient's angular calcification and the degree of posterior leaflet tethering, and of course the subvalvular apparatus. And so this is very important for us to know when we're trying to plan for procedural intervention. Looking at actual live 3D as an entirety to see the overview of the valve, this also has significant benefits over just looking at those 2D planes because it allows us to see exactly what's going on with the valve and where the predominant problem exists. So this is something called a dual volume layout where we're able to simultaneously view the valve from a surgical view from the left atrium as well as from the ventricle so that we actually can see the leaflets from underneath. And here is an example of a functional mitral regurgitation case where we see that there's a coaptation gap that's a little bit medial biased. The other advantage of this 3D overview is it can show us pathology that may be off-center, that's a little bit harder to find on 2D or that we may not have imaged as carefully. And it can show us anatomic variants such as clefts or indentations, which we sometimes will see in the center of the P2 leaflet, which again is relevant if we're trying to perform a repair like an edge-to-edge repair. Another example of where 3D echo is helpful in this overview is in degenerative MR. So like in this case, where there is a flail on the P3 side, and this can be found, of course, with 2D imaging, but in terms of communication with an interventionalist or a surgeon, or even as a team, there's very little that can replace this particular view, which immediately shows us where the problem is and what we might want to do to actually try to fix that. We already heard a little bit about advanced cinematic 3D rendering from Professor Maisano. And so these are some new tricks that are being provided now by the vendors and which give us some additional really visualization of structures. So the 3D data set's actually the same as before, but in this specific situation, it has a different rendering in terms of light source and shadowing. So again, if you want to bring out certain details, that can be quite helpful. And then there are actually new modes coming soon, including being able to adjust certain levels of transparency that again can actually show us certain parts of the valve in a little bit greater detail. Thinking again about valve intervention. So for example, for edge-to-edge repair, we care a lot about looking at the baseline valve area because we do know that we're going to significantly reduce that if we pinch the valve, for example, on A2P2 right in the middle. And so in the past, and in the original trials, such as the Everest trial for MitraClip, we looked at the valve area based on a 2D measurement. So this is a transgastric view at 0 degrees, which commonly gives us a short axis view of the mitral valve. We can measure valve area like I've demonstrated here, but the downfall of this is that we're not actually sure that we're at the leaflet tips. So we may be cutting the valve obliquely and we may be overestimating the true valve area. We can try to improve that by using biplane methods. So again, from the transgastric view, if we get a long axis view, which we see on the left side of the screen, we can biplane using that yellow line right at the leaflet tips or as best as we can achieve to try to better approximate the area right at the leaflet tips. Again, the reason I say that this is likely at the tips of the leaflets is because obviously the heart is moving as you're imaging and it's beating. And so that biplane line may still actually miss the true tips of the leaflets. So this is where, again, more advanced techniques with 3D echocardiography have significant advantages. So what I prefer doing now is actually using a 3D data set to do multi-planar reconstruction. And what that allows us to do is to actually freeze the valve at the position where it's open, and then we can reconstruct the planes to know that we're exactly at the leaflet tips, within the limits of course, this being a planar measurement, and then the true valve is often not completely planar. The downside of this method is that, again, with 3D echocardiography, you lose some spatial resolution, which we see in this example here. And again, there can be some blooming artifact and side lobe artifact. So we tend to get smaller areas when compared to 2D. Some of that is likely because we're getting the true leaflet tips, and some of it is because of the actual artifacts that we see. And then another technique with 3D echocardiography that we can use probably a little bit more than what we're doing now is actually using these advanced 3D modeling packages. And what this allows us to do is to actually recreate the valve in 3D space. And then it will give us an idea, again, of how much tenting, for example, we're dealing with, what the actual annular size is in a non-planar method. And so this reproduces a lot of what we can do already with software for CT data sets. And this is probably going to become used, more utilized in the future, even though right now we don't make a lot of clinical decisions based on information like this. So then if we move on now from the anatomy to the actual function, so mitral regurgitation, very similar to what I was discussing in terms of biplane mapping, we would do the exact same thing with the color Doppler on. And that again tells us that at each point where we've assessed the anatomy, what's happening there in terms of the function. Looking at, again, the live 3D dual volume layout, again, here we can actually see very clearly where the jet is. There's no question about it. And then when we look from underneath in the ventricle, sometimes if there's a lot of jet splaying, the flow convergence on the ventricular side, again, can very clearly identify the exact location of where a jet may be and where we really need to intervene. We obviously lose frame rate and volume rate in this situation, so it's still good to complement this with imaging without the color Doppler in place. Multi-planar reconstruction can be used again in the same fashion when we're using the color Doppler analysis. And then this can give us a very good idea of, again, where the jet is occurring, of course, within the limits of loss of spatial resolution and temporal resolution. Using multiplanar reconstruction can be particularly helpful in situations where the esophagus is not quite at the true back part of the left atrium. So in some situations, we see that the heart can be quite rotated or the esophagus is quite tortuous. And then in those situations, sometimes we're actually imaging from the side of the left atrium. Using biplane in those situations is very misleading because we're actually getting an oblique cut. And so when we use multiplanar reconstruction, we can really try to look at the valve exactly where we think we should be at every leaflet part, and then also make sure that our imaging planes, especially in the long axis, are not oblique. Another aspect of multiplanar reconstruction that can be helpful in the assessment of MR is actually looking at the vena contracta area. We know that in particular with functional MR, some of our 2D techniques may underestimate the true degree of regurgitation because you often get this type of crescentic orifice. And so if you have, again, the adequate image quality and the volume rate, you can actually use this as another method to try to quantify the degree of MR, which is not possible with 2D techniques alone. I didn't want to put a lot of data into this presentation because we're really talking about mostly technique-based, but I think that this is an important slide to just mention in terms of this graphic. So this is looking at correlation between 3D and 2D assessment for regurgitation. And on the left side, we're looking at degenerative MR. On the right side of the screen, we're looking at functional MR. And what we can see is there's actually very good correlation. So it is a method that we can use in a reliable fashion. And not surprisingly with functional MR, the 3D vena contracta area is going to be larger than 2D. And that's just, again, likely because we're underestimating the true vena contracta area in the regurgitant orifice area using 2D techniques. And then lastly, I wanted to move on to just some concepts in terms of procedural guidance and how 3D echocardiography really helps us here. So if we think about the first step of, for example, a MitraClip procedure, which is the most common procedure that we do from a transcatheter repair aspect, the first step, of course, is getting into left atrium and doing a transeptal puncture. So we can certainly image this using just normal 2D methods and switch from plane to plane. But when we use 3D techniques like biplane imaging, it allows us to provide a lot of simultaneous information, which increases the safety and efficiency of these procedures. So on the left side of the screen, we see our typical bicaval view where we're sliding the transeptal system down into the fossa. And then at the same time, on the right side of the screen, we see our short axis view, which tells us about the anterior posterior position. And then this is a perfect view to actually continue to work in because we can make adjustments to the transeptal system to try to optimize our puncture location without needing to switch back and forth. And we can understand shifts in position in multiple planes at the same time. This then brings us actually back to a little bit about the screening. So not specifically about mitral regurgitation, but for procedural planning. We can also use 3D to actually look at the fossa in advance. So it tells us again in advance where we might want to be on the fossa. So how superior, how mid, how inferior, and then again, how posterior we want to be as well. And to give us some estimate of what type of height we can expect to achieve at the time of the procedure. As we're performing the puncture, another nice technique with 3D echocardiography is to actually assess the position of our tenting, which we see on the left side of the screen, relative to the mitral valve and the mitral annulus. We like to be in line with the coaptation plane of the target of the valve. And so in this situation, for example, we see that we're relatively well aligned to our A2P2 coaptation. And also we know that this is the maximum height we're going to be able to achieve. So in areas where, the fossa is sitting low, this is a good method for us to know that we've already optimized as much as we can. And again, the measurements in three-dimensional echocardiography also make sure that we're not foreshortening our view or giving the wrong estimate over, again, the area of interest in the valve. When we're actually doing clip positioning, we, again, want to use biplane imaging as much as we can because then it gives us a lot of simultaneous information. So we can see medial lateral position, anterior posterior position, and we can understand the trajectory. And we like to follow this device throughout the procedure in biplane if we can. Again, this can be done on just two-dimensional imaging with each plane separately, but the problem is that on your alternative plane, if you're moving, you actually won't know until you switch back to have another look. Of course, if we're looking at clip orientation or device orientation, depending on what we're using, 3D echocardiography is extremely helpful in those situations because it gives us that great surgical overview and then will show us in real time what's happening with our actual device. And as you reorient the device, we can see the movements immediately in real time. And then lastly, I wanted to mention the utility of multi-planar reconstruction in a live setting. So this is actually an example from a MitraClip case that I did with the colleagues in my hospital this week. And our actual preferred method of image guidance is to use live multi-planar reconstruction throughout the entire case. And the reason is because you can see on this quad view that you can actually see everything you need to understand about your device all at the same time. So you have continual assessment of the orientation, continual assessment of the position, trajectory, and the image quality is actually good enough that you can see leaflets from a grasping point of view as well. As I mentioned with the screening, this again gives us also an advantage when we can't image directly from the back part of the left atrium. So this is very, very helpful when the esophagus is on the lateral part of the left atrium, because in those situations, you often cannot see the delivery system of the device in proper plane. And this way we can, again, properly assess what our trajectory and position is without being fooled by oblique or incomplete imaging. And then lastly, in the setting of MitraClip, once we've done a deployment, of course, part of our detailed assessment includes using 3D echocardiography and live 3D to look to see what our tissue bridges look like, what the orifice looks like medially and laterally. And then I don't have it slide specifically for this, but in situations where we're wondering about the valve area and valve gradients, you can do multiplanar reconstruction to actually measure each orifice to, again, give you a better understanding of your residual valve area. So in summary, what we've discussed in the last 20 minutes or so was really that 2D echocardiography can give us very good information about the mitral valve and is still extremely useful. But 3D echo gives us usually a more precise and detailed assessment, especially when it comes to planning or guiding procedures. And so this way, if we use it to optimize what we can do, we can increase efficiency as well as safety of these procedures. And then lastly, hopefully we've seen that multiplanar reconstruction can really help overcome a lot of situations where you have difficult imaging. And then importantly, actually allows us to minimize manipulation of the esophagus because these are long procedures and we don't want to cause any type of injury if we can avoid that. And with that, I'm happy to open it up for any questions or discussion.
Okay, thank you, Edwin. Really impressive presentation, really impressive image. When I see your images, I can think about is it necessary CT? Because it looks like CT, your 3D echo. And other thing interesting, your title, interventional echocardiographies. We're talking about this and you put in your title, I totally agree with you. And I would ask to the audience if you have any question here. Any question, Gustavo? Any question? No?
So Edwin, just
Gustavo,
a second, Edwin, about the transcatheter valve replace. Is there any specific software that may help you to help to land the valve? Is it any that you can show us?
I don't have an example, but I think, from a 3D echocardiography point of view, one of the things we are limited with in terms of during a procedure, of course, is that we're doing live imaging. And so we're really restricted to the software packages with the vendor of that specific machine. Fortunately, with the common machines that we're using, that software is continuing to evolve. So we'll probably have some nice tools in the future, but nothing that's really commercially available outside of the typical multiplanar reconstruction. I mean, there are new reconstruction packages that also allow us to download the 3D data set and reconstruct it offline. But of course, during a live procedure, that's not really a practical method, unfortunately.
Edwin, your presentation is amazing, my friend. I think that if Francesco going to say something, he's going to start saying the same. Edwin, I have a question. Do you have some software? Do you have some way of thinking with 3D echo to predict LVOT of fraction in valve replacement, let's say valve in MAC or valve in ring, let's say the other procedure? Do you have?
Yeah, it's a really great,
something.
It's a really great question. So, and that's one of the areas of a little bit of frustration as an echocardiographer. Unfortunately, we don't have as advanced tools for reconstruction and simulation like we have for CT. But, again, that is actually coming. I know there are some software platforms that are now allowing, again, importation of the 3D data set from echo. So we could do the same type of simulation, of course, again, with loss of spatial resolution, but that would allow us potentially to measure Neo-LVOT. I know that some echocardiographers have also tried to use some of the existing tools in a sort of off-label fashion. So, for example, using the 3D LV assessment to try to look at the dynamic LVOT area at rest. It doesn't give us a simulation technique, but again, maybe can give us some idea of what that area looks like at baseline. But none of that has actually been validated or fully tested in cases so far.
Thank you, but at least it's a tool to help us. Thank you, Edwin.
Completely agree.
Thank you. Let's move on to the case, Gustavo. Could you share your screen? And now we are going to present a case that you have done yesterday. After a lot of planning, I think that the name of this procedure is planning, and do the procedure. And even when you're planning everything, something changes during the procedure. And I'd like to invite Professor Maisano.
So we're going to start with the case. First, I would like to thank João that helped us a lot since I sent him the CT for his analysis, and that really changed our strategy to go with this patient. And of course, we have a huge team here, and the surgeons from our team, Tatiana, Cris, Nestor, and Leo, they are always supportive, and they put their hands on the patients with us, so we work together. Also Paulo, that is my partner in the interventional cardiologist. It's someone that has a huge experience. And of course, we had a big player coming. I said that to some friends that we were hiring for some time Lionel Messi to kick the penalty, and with help of Márcio and the other guys, I think we did well yesterday. But let's go to the case. So it's a old lady, 90 years old, female, and she about this knee occlusion, multiple admissions in the hospital. And can you hear me?
Yes, not perfect, but
are they listening?
Sort of clear.
Okay. So, but she has a very active past medical history was hypertension, diabetes. It's not showing this slide. This slide's not showing. Let me see. Not the next one. So it's still in the first slide. Ainda está no primeiro slide. Ué, mas entrou primeiro? Okay. So we're gonna we are having some technical issues, but we're gonna fix. You did it. Thank you. Obrigado, Pedro. So, and this patient had a past medical of hypertension, diabetes, chronic renal failure. She was almost on dialysis. This non-rheumatic mitral valve stenosis with a mitral valve area of 1.2 and chronic anemia also. So I would like to show this echo to Mohammed and Edwin, and try to ask them about what they think about this mitral valve.
So unfortunately, I see just a still frame image here. But certainly, even just from what I can see, I mean, this is obviously a severely diseased valve. There looks like there's at least leaflet thickening, if not calcification, in the anterior leaflet. Almost has a sort of prolapse type appearance, and then in the posterior mitral annulus, looks quite abnormal on that 3D as well. Certainly, better evaluation and additional images will also tell us exactly where the extent of the problem and where all that calcium is.
And for that half a second, I think the posterior mitral leaflet was completely frozen. So that would be nice if you can replay it.
Okay, it's not playing the YouTube. And let's try again. Let's get out and get in and to see what happened, because you can see the image but not playing, but not. Okay.
Just a second, we're gonna change the notebook, and hopefully it work. So anyway, that was a perfect definition, Edwin, like a fixed prolapse of the anterior leaflet. But it's calcium, and no, it's not working. And
So I'm sorry, I stand corrected. So the anterior leaflet seems to be completely frozen.
Can you see now?
Yes, we can see it.
Yes. Yeah, I agree with what just said. I mean, there's significant leaflet mobility restriction. And also, interestingly, the disease of the valve is very asymmetric.
You have to change the screen because you have to share this screen, not this one. Okay, that's okay now. Let's go.
Okay, so it's an issue of communication that we are in here.
Could you put to play? Yeah.
So we have these very fixed valves, and the patient had even a spontaneous contrast inside the left atrium because of it. And next, please. Cross. So João, would you mind to share with us your CT analysis of this case so we can understand what we were dealing with?
Sure. Let me see if I can. Please.
Okay, João, you could share your screen.
Can you see it now?
After we get out.
Let me know when you are able to see it.
Yeah, we can see your screen.
Perfect. Okay. So this is a Tremensio software from the data set that was received. It was a functional data set with 10 phases. And one of the first steps that we need to do is obviously to segment the mitral valve annulus, which is again is supra. It's above the mitral inlet calcification, which is ventricular. You can see similar to the images that were provided on the 3D echo. This mitral inlet calcification covers the entirety of the posterior annulus, the lateral trigone. This is the left atrial appendage. This is the surgeon's view. And also into A1 and a little bit into the mid portion, but the anterolateral trigone. So the medial portion of the anterior leaflet and the anteromedial trigone, there is nothing as far as calcium is concerned. Dimensions of the mitral annulus were large as well, 820. This is the perimeter. Trigone to trigone distance 28, intercommissural of 35, and anterior posterior of about 31. Then, we can calculate, we can look into this mitral annulus score. This is just before we go there, just to show you the distribution of calcium and how this calcium is sub-annular as well. The whole anterolateral trigone being calcified. By using this paper that we had talked about before, the calcium thickness, the distribution, the trigonal involvement in both leaflets will give us a calcium MEC score of about 7 to 8. But one of the issues is, how would this valve would sit into the medial position, whether this valve would move towards that way, an incomplete sealing of that, concern about potential paravalvular leak, and even some embolization, especially because of the area and oversizing.
João.
Yes.
Excuse me. So, as you said before, below 6 in this score is a high risk of embolization. Am I right?
Yes. Yeah, that's correct. Below 6, below 7, 6 to 7 is high risk of embolization. Again, there were two issues on that paper. One is the score, but also the degree of oversizing that one needs to achieve. And for that particular area of 820, this would be a significant undersizing, at least, by more than less than 5% of the area, nominal area for the SAPIEN 3, the 29, which is what we simulate in here. You can see that the valve also, the sealing skirt, which is about 8 millimeters or so, wants to be about 20, at maximum 30% atrialized, and the remainder into the left ventricle. When we do that, and then we can calculate the Neo-LVOT with that prosthesis, with those landmarks, we can see that the Neo-LVOT is very small, 2.2 square centimeters or 27 millimeters, when the ideal area would be in the 170, 190 or more to avoid LVOT obstruction. This is still with the aortic valve open, so we're kind of mid to late systolic phase, not with the complete valve shut. One other alternative that we discussed as well was, what if we could potentially remove or resect or perform a lampoon, or even what we discussed as well of a Citral, which is a surgical implantation, transatrial surgical implantation of the Sapien 3, that would remove the anterior leaflet. And if one was able to do that, then the skirt Neo-LVOT area would be much better, about 1.7, and 1.5 or above would be, favorable. And so whether we could try to remove that anterior leaflet or somehow open it up, that outflow tract, to allow a better passage of blood flow for this prosthesis.
Okay, thank you, João. Let's come back to our presentation, Gustavo.
Comments, Francesco?
No,
Not
first of all, I would like to hear from Joao. So his suggestion was not to do this procedure, right, Joao?
Yeah, my suggestion was that the risk for
Can you hear,
Neo-LVOT
João?
obstruction in the current context here, Francesco, would be very high for Neo-LVOT obstruction. And the suggestion was to either consider some maneuver to improve the outflow tract by either resecting the anterior leaflet, lampooning, or even, obviously a surgical resection.
So the circle that you suggested, just to inform the audience, is that the patient must be on pump. That's right.
Yes, or you would perform some sort of a lampoon to open up that anterior leaflet, given the constraints of the Neo-LVOT, which is quite small. And the septum, the basal septum that I did not show here, was only 11, 12 millimeters. So we do not have significant left ventricular hypertrophy that you could consider preemptive alcohol septoablation. So it's a high-risk case. There is no doubt about it.
Mohammed?
Concern for both LVOT obstruction as well as anchoring of that prosthesis, given the significant sizing of the mitral annulus and lack of circumferential calcification, especially on the medial trigone.
Mohammed, thanks, João. Mohammed, you had also the ability to the CT 3 or 4 months ago. I don't know if you remember, but do you have any opinion that is similar or different from João about this case?
No, I do. And if you recall, I only had the CT that you sent us, and I totally agree with Dr. Cavalcante that at least on surface, it seems that it's pretty high risk. The one thing, though, that now that I saw the echo images, it gives me another perspective of the patient. It basically adds another dimension. Is that since the anterior mitral leaflet is completely frozen, and it's frozen in a systolic phase, because if you look at your echo, it seems that the anterior mitral leaflet has closed and it doesn't open anymore. It's not that it's frozen in a semi-open position. That might be the safety mechanism, because you actually, as Dr. Cavalcante showed, your posterior calcium is not it's not even 180 degrees. Most of it is from A1 comes to maybe P2, P3, but then the anchoring phase, I think, is between your P1 to P2 and then the anterior mitral leaflet. If you go back one slide from this, the one that you have the not parasalon axis, I'm sorry, the 120 degree, the LVOT view, this one. So if we go by numbers, again, going back to the point that Professor Maisano mentioned just a few minutes ago, that all of these algorithms are great for the population studies, but not particular per patient. I agree with that. The one thing about this case, though, is that lampooning this case would be very difficult, because I've done only 2 lampoons total ever. I can tell you that one of them that was calcified was extremely difficult, and the amount of calcium on the leaflet was not even remotely close to this one. So getting through this calcium for Lampoon is going to be quite challenging. Could be done, but it's very challenging because the way that you cut down, it has to be consistent, and you want to be specifically at the middle of the anterior mitral leaflet. So from technical standpoint, to some degree, we're at the mercy of the pathology of the leaflet.
Thanks, Mohammed. As we have Professor Maisano here with a flip chart, I would, and I don't think that everyone in the audience knows what is a lampoon. I would like to Maisano to just briefly explain what it is and how it's performed, because it's not that easy. We talk about lampoon, but it's really difficult.
Okay, so the lampoon is a technique where you basically reproduce what is mitral. You get rid of the anterior leaflet to avoid LVOT obstruction. And the background of this procedure is that the anterior leaflet is potentially impinging the LVOT if you leave it in this position and you insert something in between. So if maintain the subvalvular apparatus, we maintain everything, but we make a cut like this, usually a triangular cut. This using a solution where you can do it in different ways, but basically you have to go inside of the, you have to pierce the center of the anterior leaflet, and by piercing this this anterior leaflet, either coming from the atrium or coming from the aorta, then you can, with the gooseneck, create a connection between this piercing and another catheter, and basically with the wire, with the protector, this wire, use Bowie internal electrocautery and make it leaflet, so to more or less in surgery. There is an alternative to that, and I don't think there is a lot of experience, which I think will be probably in future even better than lampooning. Perform the procedure by puncturing the middle of the anterior leaflet, and after that, implanting the valve here, towards the posterior leaflet. By doing this, what you achieve, you implant a aortic prosthesis in the mitral position. There will be for sure some protrusion in the anterior, in the LVOT, but the protrusion will be in the area where you have open cells. So the amount of reduced. This was a bit the idea. So if we go back to the case, we wanted to lampoon it. So we wanted to do a lampoon. This is the anatomy here. And obviously, Mohammed said, I think it's impossible to do it, because if you puncture here, go through the calcium to make a linear. So is a asymmetric lampoon. Never seen, but you know, in principle, you can cut here and create some, you know, eliminate a little bit of this tissue. Imagine the anterior leaflet. If you leave it towards the LVOT, it's like a sail. So if you cut on the side, it's less. If you take some of this sail out, being again to puncture here, and then push the whole calcium behind.
Let's change the mic.
Push all the calcium behind. I don't know if this would really work. I mean, this was really calcified valve. I think it was not really easy solution. Before we go into the solution, I would like also to mention that this valve is a strange valve because it's not a rheumatic valve. So one of my questions before starting was, is there any commissural fusion? And actually there was none. And this is one of the reasons why this patient has even higher risk of perivalvular leak afterwards, because the leaflets are normal. There is a calcification probably of the subvalvular apparatus. What we see there is calcification of the strut chordae of the anterior leaflet probably, and which extend somehow all in the subvalvular apparatus. This is very easy to see in CT scan rather than on the echo. Echo, typically if you look at a 3D surgical view, it looks like the calcium is above the leaflets, but this is a typical artifact of 3D. It's always making this artifact. It looks like the calcium is above the valve, the calcium is below the valve, and you can see it in 2D views. Okay, so anyhow, bottom line, yesterday, no, 2 days ago, we are in a conf call with Joao, and we are in conf call with Vinny Bapat, and they have a lot of experience. And both of them tell us no way this will work as a common valve in MEC. It will not work as a lampoon. And both of them said the only solution for this patient would be a surgical implantation through the left atrium, potentially using still a sapien valve by fixating, ablating the anterior leaflet, probably ablating the part of this calcification, and then fixating the valve with some stitches, and so on. And this obviously was one option. I think the other option would have been also this one that I was presenting to you, to puncture in front of the calcification of the anterior leaflet and pushing all the calcium behind.
Have you done that before?
No, no, but in this case also would be very complicated because as you see here in the echo here, the amount of calcium there in the anterior leaflet is a lot. So it would be, you would go and puncture through in front of this calcium. So I go back here. It would, the calcification is like
It's subvalvular.
And so you would puncture very close to the anterior, to the aortic valve. I mean, I would be very scared, to be honest, to work like this. Or the third option that, so another option obviously is to do open surgery, which is also an option. If you do open surgery, my suggestion is not even try to decalcify in an older lady. You have to accept the calcifications. You probably would only remove the anterior leaf and the associated calcification in that area. But then you leave all the calcium in the posterior leaflet, put the sutures on the leaflets themselves, and implant the valve this way. And then what I do usually, I reinforce this implantation with a patch all around the annulus to prevent perivalvular leaks. Because perivalvular leak without that maneuver will be 100%, because this calcium will not hold the procedure. So it's another high-risk procedure. So then we decided to perform a valve in MEC with let's say a supporting solution, which is something that originates from from my experience of bailouts after valve in MEC. As you know, if you have a LVOT obstruction after valve in MEC, you have different options. One option is to convert to surgery. One option is to perform on the table a septal ablation. And the other option is to stent the LVOT somehow. So either with a stent, or as we did in 3 cases before, and now this is the 4th case, you can implant a core valve, an evolut, a self-expanding. We like to use an evolut because it has much more radial force than other self-expanding devices, and because it is a supraannular prosthesis. So you are allowed to implant this valve very deep, to stent the LVOT, to help the LVOT to be opened, and to also to obtain some deviation of the direction of the mitral prosthesis towards the lateral wall, so you can't a little bit you canting the valve towards the LVOT. So, but this towards the lateral wall. But this, in my experience, has been always a bailout. So when I was flying here, that was my plan. We try to do that. We implant a valve in MEC. We know it's a problem, and I will tell you what are the problems now. In case it doesn't work, in case there is a LVOT obstruction, then we implant a evolut. So I said, Gustavo, prepare a Sapien and prepare an evolut.
Just a second, Maisano. Just to remember that we had different measurements of Neo-LVOT. That was something that we were pre-aware of it, and the help from João was something that was fantastic, because he was categorical. He was like, it's going to be obstructed, so you had to replan your strategy, wasn't
Absolutely. So that is why, again, you know, I'm always very critical I always say I always want to look at the images myself, but also it's very important to have more than one person looking at the images and listen to everybody. And at the end, somebody has to decide. And so Joao told us there will be zero area of Neo-LVOT, there will be zero. So it's not doable. And so the other problem is also that this calcium is not circumferential. And so to obtain fixation, you need to use a large valve. The idea was to use a 29, and with some risk of embolization if you don't overexpand. And again, overexpansion is another risk factor for LVOT obstruction. So we are really in a corner here if we just think a regular valve in MEC. So the idea was yesterday then to plan already a double valve implantation to obtain a couple of advantages, and I will show you what are the advantages.
Simultaneous, huh?
Simultaneous, so not as a bailout, and actually to implant the evolut first and the Sapien.
This is different, no?
We never. So let me tell you what are the what was the thinking behind. So first of all, if you implant an evolut into the LVOT, somehow you stent the LVOT. You occupy space. Secondly, the idea was to reach this calcium here, to stabilize this calcium. So by implanting the valve deep, we were really going to the level of the calcium of the anterior leaflet calcification here.
Then the landing zone is the anterior leaflet of mitral, of the
Exactly.
evolut.
So what we did yesterday, so what we did 2 days ago, I measured this distance here, and this was 1.3, which by the way is very similar to the height of the ceiling cuff of the evolut. And so by doing this, then we obtain two conditions. Number one, we keep the anterior leaflet away from the LVOT. Number two, we keep the calcium in this position, and we avoid the movement of the calcium towards the aortic valve. So a kind of a stent of the calcium. And this allowed us to think about implanting a smaller mitral prosthesis than ideally chosen. You know, in a normal valve MEC, you would choose a 29 according to the sizing of the annulus. We decided to use a 26. If you implant a 26 in such an anatomy without doing this solution, it will embolize because there will be no radial force. Enough. And it will be for sure severe perivalvular leak. But the reason to use a 26 is the following. We measured these distances here. The distance between the two chunks of calcium was, again, about 1.3 centimeter. And the distance between commissure to commissure was like 2.8. So borderline. And by using a smaller valve, obviously, the idea was to get away from the LVOT. So a 29 will go like this, will be more intrusive than a 26. But also, very importantly, using a 26 valve, the idea was also to try not to crack this calcium. If you put a 29, what will happen? To fit a 29, this calcium has to be cracked here. So if you crack the calcium, the retaining force of the calcification will be diminished, and this will be potentially, again, a risk of embolization. So the idea was, let's put a smaller valve, let's avoid the movement of this calcium by putting a stent in the LVOT, a corval. Now, then comes the last big decision making, which has been changing multiple times. The initial idea was then to implant a 26 in the mitral position, is 26 Sabian 3, and a 29 in aortic position. I have to give you some numbers also of the anatomy here. So the LVOT was very small, was again 1 point something, I don't remember, 1.5, let's say, by 2.6. So initially, we wanted to implant a 29, but then we decided not to. There are many reasons. Number one reason, it's very strange. Usually, the mitral valve should be bigger than the aortic valve. So this was already, in the background. There was like a voice. Doesn't make any sense. It's not, why the aortic valve should be bigger than the mitral. Doesn't make any sense. Second, when I measured the LVOT, I said, come on, it's too small for such a huge valve. She's a small lady. Why should we do this oversizing? We should not exaggerate. And so probably better to use a 26. And then there is a third reason. Third reason is the height of the cuff is the same for each valve. So this is probably was the most important feature. Second, you know how nitinol works. Nitinol has a radial force which is depending on the expansion. The full expanded valves have a much higher radial force than partially expanded valves. So implanting a 29 doesn't mean that you will have more radial force than a 26. This is a bit counterintuitive. We all think, we put it bigger so it will be stronger, but it's not one-to-one. So for this reason, we went for 26. Before going for 26, I was also very important to measure here the annular size to see if a low implantation would not result in a perivalvular leak. And this was not the case because it was anyhow oversized. Because at the waist, the 26 is 21 millimeter, while a 29 is 23 millimeter. There is very small difference in all these valves. And last but not least, because the valve should have been implanted by Márcio, he was very concerned about coronary obstruction in case we had to put a second valve, and we measured everything, so it was not a problem. So this was the decision making for the setup. Now the next step has been the planning of doing the procedure. Very complicated. Imagine to do concomitant implantation of two valves at the same time. It's something that we are not used to.
Never done before?
Never done before, but we plan it.
But it's a lot of planning.
We sit down and we make this plan.
This very clear plan.
Yes.
Very straightforward. No changes.
Yeah, it's a clear plan. Well, the plan was anyhow not to make it concomitant, but to make within a concomitant procedure to have some sequence. And the question was whether to put the mitral first or the aorta first. Because if you think about the usual flow, is that we try valve in MEC, it doesn't work, and we implant the aortic. So in theory, you should implant first the mitral and then the aortic. But then the background of doing this concomitant was to stent the LVOT and also stent this calcification first. So it was important to implant the valve first, the aortic valve first. On the other hand, if you implant the aortic valve now, until you implant the mitral, there might be a severe restriction of the anterior leaflet motion. So you could not really wait too long. So everything had to be prepared to be ready. And that was the case.
So the first plan would be to position the mitral delivery system at the left atrium, wait for Márcio to come with the Evolute, Márcio and Paulo come with the Evolute. They would position at the LVOT, and afterwards we would cross the mitral to implant. And that would be the first,
yes,
the first plan.
But other thing important is keep close on the top. The Evolute.
Márcio, again, this is this was really a teamwork. Everybody bringing a point. So Márcio had a very important point, very important idea. He said, I will go and deploy the valve, but not release. I keep the valve in the delivery system until you implant the sapien in the mitral so that we can play with these two valves because, don't forget that mitral and aortic, we consider there are two valves, but actually it's one valve. It's a one system which is somehow fitting in between the same continuity. It's a bidirectional valve. So the idea was to have more control by being there together.
So just to stop a little bit, any insights from the panelists from abroad? Adolfo, Ginaldo, Edwin, João.
The real audience here. Any insights?
Mohammed, you guys from here?
If I can say, my main concern is how it's going to seal the core valve being too low. Just
the aorta, you mean?
Yeah. The aorta.
Yeah. So the aorta, first of all, we measure the height. Here, the distance between the annulus and the calcification. And basically, we were able, and you will see it now in the echo, we were able to land to a distance which is enough to have the valve seated right at the point. On the other hand, again, in this small LVOT anatomy, we would expect, even if the valve was lower, we would expect some sealing. Third, in case there is a little bit of AI, it's probably helpful in LVOT obstruction. Fourth, in case this is not the case, we could even implant a valve. We were ready for a second core valve. It would be a really expensive case, but I mean, this was a point, and it was pre-discussed.
And we were sure that she would need a definitive pacemaker afterwards.
Sure, we were prepared for a pacemaker, but we'll see if it was needed afterwards.
I just wanted to make a quick comment here for the whole discussion here for this case that is fascinating, but I just wanted to also point the caution that this is not routine, a case, and we obviously are dealing with a patient that is extremely, fragile and high risk, but this is not a solution that we should be advocating for. I mean, it's a great case for discussion and the innovation that we're trying to provide, but I think, for patients that have very small Neo-LVOT, obviously, that should not be the solution, obviously, applied to every patient.
Yeah, Joao, to be very honest, I think this sentence applies to valve in MEC, not to this procedure. I don't think this is much worse than valve in MEC. if you look at I don't know what is now in the registry of Maya, the mortality for valve in neck, but it's really dismal. It's a very bad procedure. And so I am not sure that we should not be more liberal to use these approaches in this patient. But I agree with you. It's absolutely, you know, in now 5 years, I think from the first case probably was 5 years ago. In 5 years, I've done it 4 times. So it's not something that I advocate for every patient. I agree with you. And it was a solution which was long discussed with the family. By the way, the family is a very expert cardiologist. And we discussed long, more than 1 day all together as a team. So your word of caution is absolutely well taken. But to be honest, I would expand this word of caution to valve in neck. I think it's one of the worst procedures in the history of cardiovascular medicine.
I agree.
We still need a dedicated device.
Well, you know, today we have Tendyne, very good device. And I think if you think about Tendyne, some of these patients are not eligible for Tendyne because of LVOT obstruction. With such solutions, probably you can expand indications. And I'm pretty sure that somebody will come out with similar, you know, with ad hoc devices to stent the LVOT for mitral. I'm pretty sure.
Perfect. So we go on.
But it's a good point. I mean, again, Joao, don't understand me because, you know, I'm already fired because I'm a crazy guy. So I don't want to be fired.
No. I think, you know, you have to be creative. And I think, you know, that I'm excited to see the continuation of the case. Please.
So let's go into the case. Probably,
okay, so
Gustavo,
the first thing we put a provisionary pacemaker through the jugular vein. So we knew that we would leave it for at least 48 to 72 hours after the procedure. Everything was going normally, okay, no stress. You know,
well, no stress.
Transeptal puncture.
Wait a second. Yes, we had 4 axes, 5.
Yeah, that's true.
We had radial for the pigtail, plus we had additional, so transfemoral, transeptal for mitral, femoral for aortic, plus 2 other axes ready for the ECMO because, you know,
the jugular.
Nobody was really so
believing on it.
So
secure.
relaxed. Nobody was relaxed. It's a very complicated procedure. And
so after the puncture, we did balloon with a 20 by 40 balloon. We did the septostomy.
12.
I mean 12 by 40, sorry. And
a question?
Any specific features for the transeptal in these cases, height or?
So good question, very good question. We discussed a lot, and initially I thought, you know, usually I like for valve in neck, I like posterior inferior punctures. In this case, we were thinking about a more anterior because it was probably the idea to have a more aorta hugging position and get away from the LVOT. And we did a lot of discussions. And at the end, you know, I told Gustavo, this was really 10 minutes before starting. He said, we were discussing where to puncture. It's this question. And I said, you know what? Let's puncture in the middle. And we did. Because it's a good point, but at the end of the day, I don't think it's a big difference for valve in neck.
Francesco, quick question.
Right.
Do you always use 12 balloon?
Yes.
And for 29, Sapien 12 as well, or 14?
Always 12 for any Sapien. Originally, I was using a 10. I advise you to use a 12 because the problem, you're inserting a naked stent, so it gets entangled in the tissue, and if you use a smaller balloon, you get this problem more often. It is solvable somehow, but it's not nice because you are working with we have to work a lot with while the wire is in the ventricle and so on. So better to have a bit larger.
So we did the septostomy. Afterwards, we used the Agilis catheter. And do you mind to explain why you use the Agilis plus the pigtail? Is there any difference to cross the valve?
So that's a solution I like to use. First of all, because you see very well the pigtail. If you you are guided by the echo, you can see the pigtail much better than just the wire. And secondly, because if you cross the valve with the pigtail, the chance that you get in between cords is much less. It's a kind of a space. And I don't know whether it's a very important problem for valve in mech, because at the end you expand a big valve. But in general, for valve interventions where you need to have, for mitral valve replacement with every other device, you need to be really in between, in a chordal-free zone. Usually you do this flossing afterwards. But if you use a pigtail, you don't need this kind of solutions.
So then it started the turbulence. Once we crossed the mitral valve and we placed the guide wire inside the left ventricle, the patient only the guide wire. The patient started to get hypotension and with pretty much very, very unstable. So we had to take it out, the guide wire from through the mitral valve to the left atrium and reframe the strategy. And what did you think at that time?
So first of all, it's important to also underline this fact. When you listen to these procedures, LAMPOON and this and that, these patients are always very difficult to treat. These are very end-stage patients, and all these manipulations are not well not well experienced by the patient. The patient is reacting usually very bad. In this case, we crossed the valve with a pigtail, and a little bit of extrasystolic beats brought the patient from a systolic 90 to a systolic 40 immediately, and he was not coming back. And obviously, we are just at the beginning of the procedure. The idea was initially to position a safari wire in the ventricle and then cross the aortic valve with a second safari, but this was really not was pushing us. The patient was too much unstable, so I decided to pull back the pigtail and then we crossed the aortic valve with the safari, and you see now the second safari coming. And also interesting, I think, the idea about the safari wire. So we decided the wires according to Márcio because he likes safari for the aortic valve, and I don't like safari for a valve in valve or valve in max. I like a backup Meyer or a Landerquist, but to reduce the chance of instability, we wanted to have the same shape wire so that they would come in parallel. You see very well here the two wires in parallel. They behave like one, and probably they give you less problems of instability.
And in this case, it was two extra small safari. I think that's the best choice for this reason.
I mean, don't forget, small leady, mitral stenosis, hypertrophic heart, all the conditions to bring you into trouble. So what happens now? So now we have a wire in the groin. So we have a wire, both wires are ready. And I see already a valve there, no?
Yeah. So at that point, you used the guided by the echo from João Maisano, who was a really great performance from João. He was superb. And you aimed the anterior lift of the mitral valve to land the evolute. So I don't know if it's possible to appreciate well.
Let's run this
again.
Go back, yeah. You can see very well. Go back one more. No, this is already implanted. I think you have to go back more. This one. So important also here. The idea was to be guided by fluoro and use echo very minimal for this implantation, because we said we will have as a landing zone, we have the calcification, we don't need echo. And we prepared ourselves with a CT scan We knew it was a 60-40, 60 RAO, 40 caudal, a good implantation position. But at this moment, the patient was with a pressure of 30 systolic. So all our plans are gone. And I need to go fast. He was supposed to implant the valve. It was too complicated to let him in, so I implanted the EVOLT first. And I saw there was a good picture on echo, and he used echo to implant. So I changed the practice at the moment, and thanks God, there was like a communication between the two brains. He was really in the LVOT ready to see that. And so it was possible to see the calcification and to deploy the valve deep enough to obtain what we wanted. And immediately after, we implanted the Sapien 3. What do you think? Show before the implantation. Once I go back, one more. No, here. So, already. Okay, good.
I know you forgot to remove the sheath.
No, you should not participate to this.
Sorry,
you
Professor.
Want a caipirinha,
And also you are too low.
Because
sorry.
I make this mistake a lot of times. Okay, so this was a mistake, but I have to say the patient at this moment was not anymore 30, it was 0 pressure. I mean, there was really no flat curve in the pressure line. And I hear somebody made a comment too low. Actually, the starting point was 50-50 on the calcium. The problem that it went low because of we failed to
push the delivery,
to pull back the pusher. Yeah. Now, what happened? I realized that we are inflating with the pusher, and in really under stress, I don't know anything better than pulling back, pulling as I can. And so I think now we are in front of a lucky situation. We were lucky that the valve did not embolize. We can discuss why it did not embolize in the ventricle. There are many reasons, but we are also lucky that I pulled, and I will tell you why. Because in theory, to stay by the book, you should stop inflating, inflate the balloon, pull back the pusher, and inflate in the proper position. If we would do that, this valve would be embolized, because by the foreshortening, it was so low that by proper dilatation of the balloon, the valve would really embolize, would be below the calcium. What happened was by pulling like crazy, actually, the valve was fit into the calcium, got stuck into the calcium, so we were very lucky. This is not the way to do it, okay? This is really something that we were lucky. The second thing about being lucky, and this is something I would like to have the feedback from Joao here. I was thinking this morning that maybe this patient at the end, maybe we have the image of the echo afterwards. We measure the gradient afterwards.
That's
the basic gradient.
That's the final shot. You can see how it was kind of scary, the imaging.
Yes. So at the end, it's okay. It's in okay position. Yeah. You see the flaring of the valve. The valve is
and we can see some movement of the EVOLT already.
Yeah. And so what you see in this picture is very much what I was expecting. You see the valve is not in the middle of the mitral. It's gone towards the posterior medial commissure, because it's there where there was no calcium, right? So the horseshoe was open at the level of the posterior medial commissure, so the valve is not in the middle. And this is the reason why we don't have a gradient. There's almost no gradient because we are pushed on the better side, which is the posterior medial. You know, the aortic valve is not exactly in the middle. It's a bit on the lateral wall. So we are really outside of the LVOT with this valve. And so I think this is a good news. The bad news, and this is really unexpected, we were expecting the leak to come on the medial part. We have a leak on the lateral part for the same reason, because the valve shifted towards the medial part. And this is the initial jet. I think afterwards started to be a little bit better thanks to the Sapien 3 feature that has a sealing portion. And so, I mean, this MR is not insignificant at this moment, but because the valve was very low and we were really scared, we didn't do anything. We accepted this leak, which actually became a bit better after a while, and we will control the patient over the next few days. If there is a hemolysis, I think in a couple of weeks I would treat it, and there will be some healing, and it will be less risky to manipulate through this.
And as I asked about the sealing of the aortic valve, it's pretty good.
No, the aortic valve has no leak at all. And
so Francesco, Joao here. If you go back on the,
Joao, can you hear me?
Yeah, can you hear me?
Yes. So I have a question for you.
Yes. Go ahead. Francesco, I lost your audio there.
I'm not talking.
Oh, okay. I was just going to ask you, if you go back to those 3D with color,
yes.
There is, the reason for the paravalvular leak and the sealing too. It has to do, it's multifactorial. In part, obviously, is the posterior mitral inner calcification that we saw that was not going to give in, and the valve is obviously displaced towards, 2, 3 o'clock, that medial, trigone that did not have any support, right? And also, as you can see, there is some canting of that prosthesis, and that we typically see, when the coaxiality is not completely perfect. So the valve is more ventricular anteriorly and more atrial posteriorly. Can you appreciate that? Even without the collar. And then you lose the sealing skirt of that prosthesis, right? Which is about 8 millimeters or so. If you go back one without collar, you can clearly see, in that one, you play that one, you see the bottom picture is the 130, 120 degree view, that left ventricular outflow tract, and you see that the prosthesis is canted. And that, height that you have on the posterior one, plus the calcification, plus the sealing skirt favors the posterior paravalvular leak, that is the posterior lateral in this case.
Absolutely.
But you had a question for me.
But I have another mechanism, which is this one. You remember there is a horseshoe calcification, and the calcification is not the annulus. To me, this calcification is attached in the anterior leaflet to the cords. Let's say the
subvalvular.
The attachment of the secondary cord. And by implanting this valve, we mobilize this calcium anteriorly, and the effect is to open the commissure, because actually the leak is in this area, in this commissural area. You can see that pretty well also on this intercommissural view, that you get the MR coming from that portion there. But I think you're right. There is also a component of the valve being too low and canted. To be canted, this is what we wanted. We wanted the valve to be deeper in the anterior side. But again, there are many reasons for that. Bottom line,
sure.
The patient survived the procedure. The patient has no hemodynamically relevant LVOT obstruction. We measured the gradient, and actually we got different measures The worst one was 30 millimeters of systolic peak, and the best one was 0. Probably there's kind of dynamic function as well. We measured this also with echo, and there is a mean pressure gradient about 18, 20, I think. So not perfect, but good enough for such a very high-risk procedure. Now the question for you, Joao, is a deep implantation of the mitral prosthesis not a better situation than a more atrial position? You know, we always think if we go atrial is better, but I'm not sure.
I think, you know, we're still learning. There is some school of thought, especially for valve-in-valve, that we should not atrialize as much as 20, 30%. For valve-in-Mac, you're correct that because of the Mac is a subannular process, that you might have better sealing and anchoring if you try to go more 0 or 20%. Again, you wanted to use the design of the sapien valve with that sealing skirt to be encompassing the most coverage that you could potentially have with the irregularity of the Mac. So yes, in theory, you could. The problem is that this is a trade-off in this particular patient, that we don't have a lot of new LVOT. The more ventricular you go, obviously the more obstruction one would have.
But let me just tell you my thinking. I want to hear your idea, and I think you should go back, if possible, and get some CT scans, because I think the LVOT obstruction is mainly depending on the remnant of the anterior leaflet after you implant the prosthesis. The position of the prosthesis has very little to do with LVOT obstruction, because the half of the valve is uncovered, so probably is not that important. What is important is the position of the anterior leaflet. And my idea that I was thinking tonight, if you implant very low, it might happen that actually the anterior leaflet tends to go backwards and to be, and obviously the stent is deeper, but you have uncovered stent, which is deeper. So there is no big obstruction to flow. While if you implant more atrial, then you have a higher, you know, it is a conical shape. So it's more expanded now, the valve, and maybe all this portion is now covered, and you have more LVOT obstruction. This is totally thinking of tonight, and I think you should look at, if possible, I would look at the, if you have CT scans after procedure, really nice to see whether you can measure the length of anterior leaflet remnant apposition of the stent to see if this plays a role in the post-procedural gradients.
Yeah, no, that's a great point. We have had some, we have done very
Professor,
few sapien and Mac.
Back to the technique, we saw that when you implant the Edwards, the sapien, in the mitral valve position, you put the balloon a little bit forward and not center in the valve. It's always
okay,
like this.
So this is what you're talking about is the way we prepare the balloon for the sapien. This is what I do all the times. In valving Mac, valving ring, the main risk is embolization toward the left end. So to prevent that one, we want to overexpand in a conical shape, and to obtain this immediately without two times ballooning. What I do, I just, instead of mounting the sapien by the book, which you need to align the two dots exactly at the end of the stent, we do this with the dots kind of 1 or 2 millimeters above. 1 millimeter is enough, and this results at the end in and we give a little bit more volume, couple of cc more, and this results in an expansion which will be a little bit conical.
Flaring in the distal portion.
It will flare the distal portion and be more safe in terms of embolization. Obviously, we all know that this is a compromise in terms of valve function.
Yeah.
That is, but you know, you need to compromise. Again, I don't like this procedure, so I'm sorry. It's not the procedure I would love to have. If I had a tendine available here in Brazil, I would have done it, to be honest.
Okay. Gustavo?
So one question for everyone: how to quantify this leak? Because sometimes, you know, you say it's a small leak, it's a moderate leak, it's a big leak. And another thing, would you stop it here, Mohammed and Adolfo? You are in the OR every single day, or would you wait? What would you do? The first question, I would mind to, if Edwin don't mind to answer, or Joao to answer this, how would you quantify this leak?
I mean, I think formal quantification in these situations is very, very challenging. You can try 3D-based techniques, but really it ends up being a multi-parametric assessment. And then if you're really curious, potentially using additional modalities to try to understand outside of echo. But these types of leaks can be quite challenging to formally quantify.
I agree. Do you have the left atrial pressure at that time? What was the what happened there?
There was already a lot of catheters. That is too much. But yeah, I'm a lover of LA pressure, and to be honest, I don't think the problem in this patient is the leak in terms of hemodynamic consequences. And the leak was not so dramatic, and it's improved at the end of the procedure. What makes me worried is hemolysis. I mean, this could be really happening in such a condition. So
yeah,
again, we will see.
Of course.
I think it was really a good decision to stop there and observe the.
And that's what I was good.
What happens.
Yeah, that's what I was going to say. I agree with what Edwin and Dr. Cavalcante mentioned. The one thing is these patients, though, Professor Maisano, they inherently, the fact that they have calcium in the myocardium already tells you that these patients have the most severe form of diastolic dysfunction. The one thing that is very important to me is the E wave across the mitral valve before the procedure and what happens afterwards. Because one thing with the LA pressure, again, I follow you. I fully agree that LA pressure is very important, but we also have to remember that the compliance of the left atrium plays a significant role. To me, it's not just about how much volume is going to the left atrium. What's important is just at least just as important is what happens to the V wave, because there are cases, and we see that all the time, especially with surgical MVR, that it only takes 15-20 cc's of volume to shoot the V wave through the roof, and those are the patients who on echo it may not seem much, but clinically the patients don't do well.
I agree with you. You make a point which is very important, maybe not for this particular case, because again, we are talking about a life-saving situation, and even if there is a problem with a V wave, I don't know what I can do. I mean, besides closing this perivalvular leak. But what you make a point is very important, and is also my observation. When we treat patients with MR and with MitraClip, for instance, where I like to have a V wave tracing to guide my decisions, sometimes we see these patients coming to the lab with a very flat LA pressure line. These patients have usually long-standing disease, the left atrium is compliant, and they come probably a little bit hypovolemic. And you should challenge these patients with volume 100 cc, 150 cc, and you will evoke a tremendous V wave without any change in the degree of regurgitation. So it's independent from the color Doppler. You see no difference in color Doppler, a huge difference in V wave, because you go into the Starling curve of Laplace, let's say, of the, so you put in crisis the left compliance and you get these V waves. So V waves are also absolutely volume dependent, and we need to understand that in some occasions you need to do a stress test of these patients to provoke a hemodynamic disturbance.
Totally agree.
Thank you. Let's come back to the. You can, come back. You can talk about the ST, please.
So because of the septostomy, we can appreciate this ASD, but we won't close it because of the leak that we're gonna be reassessing next week to see if it's smaller, and if we need to close it, we're gonna have some help from Pablo and Márcio and Joao to close it.
Gustavo, may I have a suggestion? Sometime, unless you have
Professor
right
Maisano,
connection, or I'm sorry if I may say something about the
related to
intraocular
this
septum.
procedure, and I was thinking about this yesterday and today, seeing you. First of all, congratulate for this beautiful case. It was amazing. And the guys, Márcio, Gustavo, Paulo, Edgar, and all the guys, João, for this. My question is about take benefit from the Dr. Maisano presence here. I know it's very hard to predict the future. It's an exercise, we know that. But as you said, in Brazil we have some, I'm gonna talk about the med school and formation. We have to be interventionalist, 2 years of internal medicine. After that, general cardiology, and then intervention for 2 or 3 years. And for surgery, we have 2 years. No, it has changed because it was general surgery, just like learn how to make stitches and appendicitis, and they have changed it because they're seeing the future is, I mean, hybrid. And so they have 4 years of surgery, cardiac surgery, and 1 year endovascular, that would be intervention. I don't know in Europe, what do you think? And the question is, what do you think for the future? We're gonna be one specialty hybrid, or we have to learn how to make stitches, the interventionalists, and the surgeon have to learn how to puncture and how to make a study, just a catheterization. What's are your thoughts for the future? Thank you.
So it's a question I have also, I don't know the answer. I can tell you what is my experience and what I profit from my experience, and what has been also my pathway to get to this experience. So first of all, in the year 2000, more or less, I start thinking about I need to learn wire skills. And the idea was because I was already working in the animal lab and seeing these things happening. And it was clear to me at that time. At that time, I was already fully trained in cardiac surgery. I was doing from aortic to ventricular remodeling, everything. I was making every kind of surgical procedures, just like every cardiac surgeon wants. And I decided I would dedicate to valves. I would abandon. I was proctoring Medtronic. I was proctoring beating heart surgery. This was my main expertise. But as I saw this, I said, this is the future. So I will do this. But also the decision was to abandon most of classical cardiac surgery and focus on valves. So I still operate a lot on valves. And so I narrowed my expertise on competence rather than on skills. I expanded my skills, but I also narrowed the competence. Obviously, I can still do bypass surgery because I've been also for many years a director of a cardiac surgery unit. So at the end, I do transplantation, but this is probably not needed in the future. I believe that the future should be based on competence. The fact that you can push a wire is not so difficult. I mean, I think you can teach pushing a wire to somebody in 6 months. What you cannot teach in 6 months is to decide whether ASD should be closed or not. Whether a complex situation with ASD, mitral stenosis, and aortic regurg needs 3 procedures or 1 procedure. So the competence is going to be, in my opinion, the focus. Now, how you collect the skills around the competence, this is an open question. My opinion, honestly, my personal opinion is that if you have no technical limitations, and you have no leak, no black holes in your competence, you're very strong. And competence means you need to know everything inside of your business about different skills, pathology, imaging, everything, because it's normal. You interact with others. If you have that, you are very powerful. But you can also be powerful with a unit made of people with the same intention. So the heart team, but not the heart team where you have a surgeon who does transplantation, valves and coronaries. No, you need a heart team, you need a coronary surgeon who does coronaries like beautiful. And then you need somebody who does complex PCI, beautiful. You need a unit for complex coronary disease. You need a unit for valve disease. You need a unit for heart failure. So I think the future will create also hybrid professionals which are fulfilling the need of these teams. Because we go in that direction, at least in Europe, also the reimbursement will change. Will not be anymore based on procedures, it will be based on decisions. It will be value-based. So decision not to do probably will become even more important than to do. So we should abandon this idea of skills or technologies. We have to become a bit more open to change our perspectives.
Any question?
The personal
just
wisdom is always from Professor Maisano.
To tell everyone how I feel, I was very pleased to be here and to participate of all this that this patient brought to us, and especially made us think different. Just what you said over here today, the most important thing that we can extract from all these is that we are crossing boundaries. And all this discussion with João, I think he is very clear at his point that he's defending the bounds that are already pointed in the data available. But this case is not on label. This case is a person who needs something. She's 90 years old, but she has a clear mind. She has very good relationship with her family. She is alive, but she needs treatment to go on. And you taught us how to think out of the box and use our skills, our knowledge to find out a way to give her what she needs. Congratulations. Thank you.
Thank you for the comment. I just want to clarify that it has been one of the most complex procedures in my life, which means for this patient has been a very high risk, and I'm very aware of it. And when I see people reluctant saying don't do it at home, okay, I understand. On the other hand, it's not a decision which has been taken easily, and it was very highly supported by a good plan behind, a good understanding of anatomy. And I'm not sure you can do this in many patients. In this particular patient, I think it was a good strategy because we were working on this amount of information. We had all the imaging available. We had the suggestion from others. So using collective knowledge is not, congratulations should be given to the team. Each of us has brought something to the final result. My personal contribution, obviously, I was, let's say, lucky because I had complications in the past which were solved by this LAMPOON. And then I made a reverse engineering. Say instead of bailout, let's do it from the very beginning. Okay, and then thinking about how to implement in this particular patient, I always, although I like these studies with these algorithms, these scores, fantastic, you publish on Lancet, but you don't use it for the patient. At the end of the day, I knew that I need 26 because I go and measure the calcium in that patient, how distant it is from the annulus, and we decided to do like that. So you need some degree of handwork, some degree of craftsmanship in these procedures. These are structural interventions. This is not mathematics. Then the mathematics we need. I love it because they give you an overall picture. I think as much as education is going to change, in my opinion, in the next 10 years, we will see the end of the evidence-based medicine. Because evidence-based medicine has been too much aggressively influencing our decisions. How is evidence-based medicine done? It's made on average response to a therapy, average. So if I go to a restaurant, I want to go to a top restaurant. I don't want to go to a mediocre restaurant. And average means mediocrity. So if you want to have a mediocre treatment, go by evidence. If you want to have a treatment made ad hoc for you, obviously you're not crazy. You look at the evidence, but you adapt the evidence to your specific problems, because the evidence is not a bell curve. The evidence is you go in the middle of the bell. How many of our patients fit in the middle of the bell? Very good. Almost all our patients are not cannot be fit in any of the trials. So we get some form of guidance, but this guidance should be really provided with additional data, and that's why we need to run a lot of registries. We need to have more real-world data, but more reliable real-world data. This is the problem. We need to learn from experience using having more controlled, non-randomized trials. This is, in my opinion, will be the next future. And we have an idea for 4 valves, but I cannot tell you now because otherwise they steal from us. But it's about the wisdom of the crowd, which is actually what happened here. Wisdom of the crowd means outside of evidence, we used our brain all together and we got to a solution out of the box.
Okay, thank you, Francesco, for these fantastic comments. That medicine-based evidence put the best and the worst in the middle. That's it. Moving to the end of our presentation today, I would like to invite some international panelists abroad. We can start for Mohammed. Mohammed, could you say anything? Your final considerations, please.
An amazing session. It was an amazing day. It made my week, actually. The only comment I wanted to bring up here, since Gustavo mentioned that he's thinking about closing the ASD, possibly closing the ASD, not necessarily, is that please be very careful unless she has right to left shunt or bidirectional shunt. And when I say that, not just by the resting echo, ask the patient to walk around a little bit, and it doesn't take much. Usually 20 seconds, 30 seconds is enough, and repeat the echo. If you don't see any evidence of bidirectional shunt, or right to left shunt, just leave it be. Actually use that ASC as your friend. It's going to reduce the LA pressure better. I've made this mistake once before. Very early on, I think I was just fresh off my fellowship, and I thought that, okay, I'm going to close the hole, because as a structuralist, anywhere that is not a hole, we want to create a hole, and if there is a hole, we want to plug it, right? This is just our natural knee-jerk reflex. But I cannot tell you how quickly the patient deteriorated on the table, and I had to take it out, and that patient was very high risk anyway, but this patient is just as high risk, if not higher. So be very, very mindful. Think not twice, think 5 times before you close that ASC.
Thank you, Mohammed. Edwin, do you want to say some final comments?
Yeah, I think overall, I mean, really amazing case to discuss and sort of see how it played out. I completely agree with the sentiment that really that team-based model and using everyone's expertise and experience is so key in these sorts of situations, because you're right, these are not trial patients, so you can't really apply the results of big randomized trials to these sorts of cases. It really has to be an individual case-by-case discussion, evaluation, plan, and then as a team be ready to adapt to whatever happens.
Thank you very much. João, are you there? No? Oh, okay, thank you. So, Adolfo, I would like to say this session is already done in memory of your father. We have our condolence, and I would like to hear your final comments, please.
Yes, thank you, Márcio. I was supposed to say that I am really happy to be here, and those days it's not easy for me to be happy. So I am very thankful of you and for Boas team. Regarding to the case, I think that it was very nice solved. Sometimes, I have learned that from Francesco. You have to bring a solution out of the box. You had to try to give something to the patient, and I think that this combination of knowledge coming from different perspective or different specialty in your team was the key for the success. And I only have to say I congratulate you all. And again, I will say thank you very much for inviting me to this session.
Thank you, Adolfo. And I know that I can't forget him. Rinaldo, my friend.
Hi, my
Open
friend.
your mic. Yeah.
It was a
Your
pleasure.
final comments, please.
It was a very particular case in which we could learn concepts to be applied beyond in our life, because very special cases happen in our real life. Besides this, intervention should be who is prepared, who is know how to do. And besides this, we must work as a team. Together, we are stronger and can help our patient.
Thank you, Rinaldo. And to the end, I'd like to invite all the doctors who has attended the cast of Professor Maisano to come here in front of, please, Vinicius, Nestor. And it's an honor to have Professor Maisano here, and I'd like to call you to a big applause for him. This is the most important guy here. Thank you, Professor Maisano. It's the fruit of your passion. Thank you very much. So we are finalizing the transmission. Good to see you here, and I'm waiting for you in the next transmission. Thank you. Bye-bye. See you in the next.
Bye, Edwin. Bye, Mohammed. Bye, Adolfo. Good to see you again.
Goodbye, everybody. Have a nice weekend.